Right. So the today's topics for the rapid revision as a part of the medicine part two will be like yes. Am I audible to all of you? All right. Okay. So fine. So the today's topic for the remarkable rapid revision will be the cardiology, neurology, connective tissue disorders, gastroenterology, and as well as the hepatology. All right. And yes. So now first let me start with the connective tissue disorders. Right. So in the connective tissue disorders, just go through this question quickly. So a middle-aged woman, right, with the history of back pain came to the OPD, right? On examination, she was positive for the Schober's test. Her nose and ears, her nose and ears were hyperpigmented. What is your diagnosis? Any one of you? Yes. What is the answer? Right. Okay. So, right. I know majority of you will answer D, but answer is not the ankylosing spondylitis. And you know what is the answer? The answer is the ochronosis. Now, why is it ochronosis? Why isn't it the ankylosing spondylitis? Let me tell you. Okay, so we have Pratyusha answering it correctly. Very good, Pratyusha K. So now, first of all, ankylosing spondylitis, please tell me, is it more common in males or females? Ankylosing spondylitis is the one which is more common, right? It is more common in males rather than females. That is the first point. And in patients with ankylosing spondylitis, the hyperpigmentation will not be seen, right? Hyperpigmentation, which is there in this patient, will not be observed in patients with the ankylosing spondylitis. And among the options which has been given to you, where will you have the hyperpigmentation is, that is in case of the ochronosis, right? And what exactly is the ochronosis? Ochronosis is a bluish black discoloration of certain tissues, right? What are the tissues where there will be bluish black discoloration in case of the ochronosis is the ear cartilage, right? There will be hyperpigmentation, and even the ocular tissue, there will be hyperpigmentation. And where do you see this ochronosis is in case of the alkaptonuria, which is a metabolic disorder. Okay. And in patients with ochronosis, there will be also involvement of the spine, right? And that is the reason why the Schober's test will be positive, right? That is the reason why the Schober's test will be positive. Okay. Right. And next is you take this ankylosing spondylitis. Why isn't it ankylosing spondylitis? Is because the hyperpigmentation is not the feature of, right. So the hyperpigmentation is not the feature of your ankylosing spondylitis. And even your hypoparathyroidism, that too, that can be easily ruled out. Okay, because you don't have this particular picture of your Schober's test and all in case of hypoparathyroidism. Now you take this fluorosis. Fluorosis, hyperpigmentation is not explained by the fluorosis, right? And in fluorosis, what is very important is dental symptoms. And the dental symptoms are not observed here. So that is the reason why your fluorosis is also ruled out. Okay, right. And yes, Karthik, I will send the, okay. Right. I will send this PDF after the your session is over. Yes, Karthik, I will send you the PDF after the session is over. Right. Now you take in patients with the ankylosing spondylitis. What are the important structures which are being affected in patients with the ankylosing spondylitis? In patients with ankylosing spondylitis, it is mainly the involvement of the spine, right? And that too, which part of the spine is very commonly affected in patients with ankylosing spondylitis is that is the lumbosacral spine. That is the one which is affected first in patients with the ankylosing spondylitis. And followed by that, you have the ascending involvement in the spine in patients with the ankylosing spondylitis. And next to the spine, the other joint which is very commonly affected in patients with ankylosing spondylitis is it is the sacroiliac joint, which is very commonly affected. Okay, it is the sacroiliac joint which is very commonly affected in patients with the ankylosing spondylitis. Okay, two important structures. एक spine involvement होगा, दूसरा sacroiliac joint involvement होगा. Now, in patients with ankylosing spondylitis, you also have extra articular manifestations. So ankylosing spondylitis patients में extra articular manifestations भी रहेगा. Now, what are those extra articular manifestations in patients with ankylosing spondylitis is the most common extra articular manifestation is in the form of the anterior uveitis. So ankylosing spondylitis में most common extra articular manifestations क्या होगा? That is anterior uveitis. Then what will be the cardiovascular system manifestations? Cardiovascular system manifestations जो है that includes aortic regurgitation, ischemic heart disease, and third degree heart block. And you also have the involvement of the spinal cord that will be in the form of the cauda equina syndrome. And you also have the involvement of the respiratory system that is in the form of the upper lobe fibrosis of the lung. Okay. Now, what is the test that will be positive in patients with ankylosing spondylitis? Yes. ये test का नाम क्या है? What is the name of this particular test? So this particular test is nothing but the Schober's test. The Schober's test is the one which will be positive. Okay. And what is the role of Schober's test? Schober's test का role क्या है? So that will tell you about the assessment of the flexibility of the spine, right? So that will tell you about the flexibility of the lumbosacral spine. So that is what is the importance of the Schober's test, okay? And next important is X-ray में क्या दिखेगा आपको ankylosing spondylitis में. So in patients with ankylosing spondylitis, the X-ray will show you what is called as the bamboo spine, where you have the fusion of the vertebra. Right? That is very important that you will observe. And another important X-ray finding in patients with ankylosing spondylitis is that you have the presence of the dagger sign. Right? And what is this particular dagger sign? It is the ossification of your supraspinous and as well as the interspinous ligaments that will give you this classical dagger sign. Now, can anyone tell me where do you get this dagger sign in the ECG? ECG में dagger sign कहाँ पर रहेगा? Any one of you? Where will you have dagger sign in the ECG? Or where will you have dagger shaped Q waves? In which clinical condition you will have dagger shaped Q waves? Anyone? Yes. You will have very good. So Nachi, very good. And yes, Chiranjeev, right. So all of you are answering it correctly. So in patients with hypertrophic obstructive cardiomyopathy, you will have the presence of dagger-shaped Q waves. So these are some of the important points related to your ankylosing spondylitis. And what is the drug of choice in patients with the ankylosing spondylitis? We need to give indomethacin. Okay, indomethacin is the drug of choice. And finally, the last question on ankylosing spondylitis is, what is the HLA in patients with ankylosing spondylitis? Any one of you? What is the HLA in patients with ankylosing spondylitis? The HLA association in patients with ankylosing spondylitis will be right. So all of you are right. So that is the HLA-B27, which will be positive. And at the same time, you need to be very much aware of like what are all the other conditions where you have the HLA-B27 being positive, right? Please tell me what are all the other conditions where you have the HLA-B27 being positive. Any one of you? Just please remember this mnemonic, that is PAIR. What does this PAIR stands for? P is your psoriatic arthritis. A stands for ankylosing spondylitis. I stands for the inflammatory bowel disease. R stands for retards or the reactive arthritis. Retards or reactive arthritis. So these are the conditions where you have the HLA-B27 being positive, right? So this finishes the discussion related to your ankylosing spondylitis. Okay. Now we will move on to the discussion of another important connective tissue disorder, which is nothing but your Behçet syndrome. Right. Any one of you? The following features are suggestive of Behçet syndrome except orogenital ulcer, polyarthritis, uveitis, and libido reticularis. Very good. So, right. So the one that you don't see in patients with the Behçet syndrome is your libido reticularis. Okay. So what exactly is your libido reticularis? It is a reddish, violet, reticular discoloration of the skin. Right. It is a reddish, violet, reticular discoloration of the skin. And this libido reticularis, it is mainly observed over the extremities, that is over the limbs. And why is it caused? It is caused by an interruption of the blood flow in the dermal arteries. Right, due to interruption of the blood flow in the dermal arteries, you have the development of libido reticularis. And this libido reticularis is not observed in patients with the Behçet syndrome. Now, can anyone tell me in which form of vasculitis you have this libido reticularis? Any one of you? In which form of vasculitis you have libido reticularis? Any one of you, please? Yes. In which form of vasculitis is my question? Your libido reticularis will be positive. I mean, present. And I'll give you a clue. It is a form of medium vessel vasculitis. Okay. So what is that form of medium vessel vasculitis where you will have the libido reticularis being present? Okay. That is in case of your polyarthritis nodosa. In polyarthritis nodosa, you have the presence of the libido reticularis. Okay. Now, let us talk about the Behçet syndrome. Right. Okay. So, like if you take this Behçet syndrome, the characteristic feature of your Behçet syndrome is the presence of the aphthous ulceration. And that too, it is like recurrent oral aphthous ulceration. Right. So this is a characteristic feature of patients with Behçet syndrome. And this is nothing but your sine qua non for diagnosis. That means without your oral ulceration, it is not called Behçet's at all. And this particular ulceration or ulcers, right, they are very, very painful. They appear almost 3 times in a year. And whenever they disappear, you don't have any scar formation. And not only the oral ulcer, this Behçet's, it is also called as oro-oculogenital syndrome. This is another name for the Behçet's, right? Oro-oculogenital syndrome. Now, what is that you have to remember is, it is not only the oral ulcer that you will have in these patients will also have the genital ulceration. Okay, so this will be the genital ulcers, which can be present over the glans penis. But the ulcers which are formed over the genital area will leave a scar formation in case of your Behçet's. Okay, then in patients with Behçet's, you also have the involvement of the eye, that is ocular involvement. And that ocular involvement will be in the form of the anterior uveitis. Right? The ocular involvement will be in the form of the anterior uveitis that you will have in patients with the Behçet's. And in Behçet's, you also have the skin involvement. And what will be that skin involvement in patients with Behçet's? That will be in the form of the erythema nodosum and as well as the acneiform eruptions. Right? Erythema nodosum and as well as the acneiform eruptions. Now, the question related to your Behçet's is, what is the name of the test that will be positive in Behçet's? Yes, what is the name of the test that will be positive in Behçet's? Right? Very good, Chiranji. So, it is the positive Dr.G test. Right? It is the positive Dr.G test that you will observe in patients with the Behçet's. Now, finally, you need to know the treatment of these patients with the Behçet's. So, like you have that oral ulceration. So, for that oral ulceration, what is that you need to apply is, you need to apply the topical steroids. Okay. So, topical corticosteroids, that is oral dexamethasone, is being applied. Okay. And the other supplementation which you can give for the oral ulcer is, apart from the topical steroids, you can also give apremilast. Right? You can also give apremilast. Okay. So this is another supplementation that you will be giving in case of your Behçet's. Okay. This finishes the topic of your Behçet's. Very important manifestation is recurrent oral aphthous stomatitis. Right? Next. Moving on to the next question. Most common organism that is responsible for the development of the reactive arthritis. See, what is another name for reactive arthritis? This is also called as the Reiter syndrome. Right? This is also called as the Reiter syndrome. Any one of you? The most common organism associated with the reactive arthritis. Right. So this Reiter's or reactive arthritis, it is secondary to the sexually transmitted disease, right? Or it is secondary to the gastrointestinal infection, right? And your secondary to your sexually transmitted disease, this is caused by your chlamydia, right? This is caused by chlamydia. Whereas secondary to gastrointestinal infection, that is caused by your Shigella and as well as the Salmonella. But which is most common in responsible for the development of your Reiter's or reactive arthritis is your sexually transmitted disease, that is your right sexually transmitted disease, that is your chlamydia, that is the most common. Chlamydia is the most common. Okay, next. Now in patients with your Reiter's or the reactive arthritis, they have this triad. What is the triad that you have in patients with your Reiter's or reactive arthritis? You have the asymmetrical arthritis, mainly the involvement of the lower limbs, and there will be also urethritis, where these patients will present with burning micturition. And there will be also conjunctivitis. This is a triad: arthritis, urethritis, and conjunctivitis. That is what is classically seen in patients with the Reiter's. Now, the next question is, what is this skin manifestation in patients with the Reiter's called as? Yes, what is the skin manifestation in patients with Reiter's called as? Yes, any one of you? The skin manifestation in patients with the Reiter's, that is called as keratoderma blennorrhagica, right? Keratoderma blennorrhagica, okay, right? Which is nothing but your hyperkeratotic vesicles that are present over the palms and as well as the soles. And in patients with your Reiter's or reactive arthritis, what is the treatment that you need to give? It is mostly secondary to your infectious pathology. So we give the tetracycline group of antibiotics, right? Mainly to kill that is your doxycycline, mainly to kill that your chlamydia. And for arthritis, we give the NSAIDs, right? We give the NSAIDs. Okay, so that is how you treat these patients with the Reiter's or reactive arthritis. And what is the HLA that you will have in patients with Reiter's? What is the HLA that you will have in patients with the Reiter's? The HLA that will be positive is your HLA B27. That is similar to that of your psoriatic arthritis, ankylosing spondylitis, inflammatory bowel disease, and Reiter's or reactive arthritis. All right. Okay. Your Kranti Reddy, your HLA B51, that is in case of Behçet's. HLA B51, it is in case of Behçet's. All right. Okay. Now, yes. Please answer this question. This is the question related to the topic of the SLE, that is systemic lupus erythematosus. Any one of you please answer this question. A 32-year-old woman with long-standing diagnosis of your systemic lupus erythematosus is evaluated by her rheumatologist as a routine follow-up. A new cardiac murmur is heard and echocardiogram is ordered. She is feeling well, right? She is feeling well and has no fevers, weight loss, or pre-existing cardiac disease. A vegetation on mitral valve is demonstrated. Which of the following statement is true? Blood cultures are unlikely to be positive. Glucocorticoid therapy has been proven to lead to improvement in this condition. Pericarditis is frequently present concomitantly. The lesion has a low risk of embolization. The patient has been superficially using injection drugs. Yes. Okay. So I did not get the correct answer. Right. So I did not get the correct answer from any one of you. Right. Okay. So first of all, which is the true statement? Now, what is this particular patient suffering with? There is like a new onset cardiac murmur. So new onset cardiac murmur, tell me, is it like pericarditis, myocarditis, or is it endocarditis? Okay, now some of you are answering correctly, right? Rajeshwari, Munshi, and as well as Jagan Mohan Reddy and Kranti Reddy. Now you are correct. So blood cultures are unlikely to be positive. That is the true statement. Okay, so first of all, tell me, what is this patient suffering with? Is it like pericarditis, myocarditis, or endocarditis? Hmm? So this particular patient is suffering with the endocarditis because vegetation on the mitral valve is demonstrated, which is nothing but your Liebman-Sachs endocarditis. Now, in case of your, yeah, Munshi, very good. Right. So in case of your Liebman-Sachs endocarditis, we don't give steroids. What is the treatment for your Liebman-Sachs endocarditis? The treatment for your Liebman-Sachs endocarditis will be valvuloplasty, right? But for pericarditis and myocarditis, you can give your steroids, but not for your Liebman-Sachs endocarditis. That is the reason why your option B is an incorrect statement. Okay. Now, pericarditis is frequently present concomitantly. That is also a question mark. Otherwise, pericarditis is the most common cardiac manifestation in patients with the SLE. But pericarditis is frequently present concomitantly is a wrong statement. Okay. And the lesion has low risk of embolization is also a wrong statement. See, these patients with vegetations, they have like high risk of the embolization, right? And the patient has been superstitiously using the injection drugs. That is the wrong statement. See, the patient has been superstitiously, or sorry, surreptitiously. That means increasingly using injection drugs that you come across in patients with the IV drug abusers. In IV drug abusers, please tell me which valve is commonly affected, right? Which valve is commonly affected in patients with IV drug abusers? Anyone? Right? No, 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 no. In case of the IV drug abusers, it is mainly the right-sided valves which are very commonly affected. That is, the tricuspid valve is very commonly affected in patients with the IV drug abusers. Okay, so that is the reason why now the question says that there is involvement of your mitral valve. So that is the reason why option E is a wrong statement. Okay, so which is the correct statement here? The blood cultures are unlikely to be positive because the vegetations that you have in patients with the systemic lupus erythematosus is they are like sterile vegetations. Now, what is that condition where you have unsterile or non-sterile vegetation is that is in patients with infective endocarditis. In patients with infective endocarditis, you have like the non-sterile vegetations. All right. Okay. Now, let me tell you few points about your systemic lupus erythematosus. So, like everyone should be very much aware of this particular 11 criteria of your systemic lupus erythematosus. This is one of the very famously used mnemonic for remembering the criteria of SLE, right? You wash your brain with soap, then you get your MD seat. Okay, this is one of the mnemonic. So what is this particular soap brain MD? S is your serositis, right? That is pleuritis and pericarditis. O stands for oral ulcer. A is your arthritis. P is your photosensitivity. B stands for blood disorders, that is in the form of pancytopenia, that is anemia will be there, leukopenia will be there, and thrombocytopenia will be there. And the anemia that you see in patients with SLE will be hemolytic anemia, and that too it is autoimmune hemolytic anemia, right? And renal involvement will be there, that is in the form of the lupus nephritis. Okay, and if you take the most sensitive test, that will be your anti-nuclear antibody, right? And what will be the most specific? That will be your anti-Smith, and the one which will tell you about the CVRT is your anti-dsDNA. And neurological manifestations will be there in the form of seizures and psychosis in patients with the SLE. And malar rash and discoid rash, these are the cutaneous manifestations in patients with the systemic lupus erythematosus. Okay, right. Now, this is your classical malar rash, which are present over the malar eminences. Okay, and you have many differential diagnoses. In which valvular heart disease you have this malar rash? In which valvular heart disease you have the presence of the malar rash? Any one of you? So that is in case of the mitral stenosis, you can have this particular malar rash. Okay, right. Then, yeah, very good, Nachi. Then, yes. So this is your discoid rash, which is present in patients with the systemic lupus erythematosus. Now, photosensitivity is another important manifestation in patients with the systemic lupus erythematosus. Now tell me, what is the treatment for this photosensitivity apart from sunscreen? And next is, what should be the antibody in patients with SLE for the development of photosensitivity? These are the two questions. What is the treatment that you will give apart from sunscreens? And what is the antibody in SLE that will be responsible for the development of your photosensitivity? Anyone? So the treatment, right? The treatment that you will be giving is your hydroxychloroquine, right? And the antibody that will be responsible is your anti-Rho antibody, right? The presence of anti-Rho antibody in patients with SLE is the one which will be responsible for the development of photosensitivity. And in patients with your SLE, you also have the presence of the ulcers, right? The oral ulcers will be there in patients with the SLE. And they have arthritis. What you have to very importantly remember is it is non-erosive arthritis in patients with the SLE. It is not erosive arthritis that we see in case of your rheumatoid arthritis. And in patients with SLE, it is mainly synovitis and then followed by that non-erosive arthritis. And you need to know what will be the respiratory manifestations in patients with the SLE, right? Yeah, Chiranjeev, your anti-Rho antibody is present in two scenarios. One is in case of neonatal lupus, and as well as even in the scenario of your photosensitivity also, you have anti-Rho antibody. Okay. Yes, Vikas. Jacob's arthropathy is seen in case of rheumatic fever. In rheumatic fever, one of the complication is your Jacob's arthropathy. All right. Okay. Now, yeah, respiratory manifestations in patients with your systemic lupus erythematosus, that will be in the form of the pleural effusion, right? That will be in the form of the pleural effusion. And not only pleural effusion, there can be even pleuritis. And because of that, the patient will present with the severe form of the chest pain. Okay, right. Then, okay, so pleural effusion. And next is the pleuritis, right? Next is the pleuritis. And these patients will also have the interstitial lung disease as well, right? And one of the very rare manifestation that you will have in patients with the SLE will be shrinking lung syndrome. And why is this particular shrinking lung syndrome? The shrinking lung syndrome is mainly because of your diaphragmatic myopathy. So that is due to antibody formation against the diaphragm, and that will result in the paralysis of the diaphragm, where thereby the dome of the diaphragm increases, and that will compress the lung parenchyma, and that is what is called shrinking lung syndrome. Okay, and what will be the cardiac manifestations in patients with the your SLE? Cardiac manifestations will be in the form of the pancarditis, right? And out of this pancarditis, that is pericarditis, myocarditis, and endocarditis, your pericarditis is the most common manifestation in patients with the SLE, where these patients will present with chest pain. And your pericarditis and myocarditis that can be treated by steroids, but Liebman-Sachs endocarditis, right? You need to do valvuloplasty, right? You need to do valvuloplasty. Okay, right. Now, regarding the clinical scenario and treatment of this patient, you see here, we have a 45-year-old woman with SLE presents to the emergency department with complaining of the headache and as well as the fatigue. Her prior manifestation of SLE have been arthralgia, hemolytic anemia, malar rash, and as well as the mouth ulcers. These are the prior manifestations of the SLE. All right. Now the question is, she is known to have high titers of antibody to double-stranded DNA. So anti-dsDNA is present. That means it is suggestive of your SLE. She is currently taking which drugs? The prednisolone and as well as the hydroxychloroquine. Okay, prednisolone and hydroxychloroquine. On presentation, she is found to have the blood pressure of 190, and that is the reason why headache is there. Heart rate of 98 beats per minute. Urine analysis show 25 RBC, 2 plus proteinuria, no RBC, cast are identified. Blood urea nitrogen is 88 and serum creatinine is 2.6. She has not previously had renal disease related to SLE and is not taking the NSAIDs. She denies any recent illness, decreased oral intake or diarrhea. What is the most appropriate next step in the management of this particular patient? Initiate cyclophosphamide. Second option, initiate the hemodialysis. Third option, initiate a high dose steroid therapy and then mycophenolate mofetil, initiate plasmapheresis, withhold all the therapy until the renal biopsy is performed. Hmm? Right, very good, Jamal and Chiranjeev, excellent. So first of all, tell me, what is this patient suffering with? First of all, tell me, what is this patient suffering with? So this particular patient is suffering with acute lupus nephritis secondary to your systemic lupus erythematosus, right? And along with infection, lupus nephritis is the most common cause of death in the first decade of life. Okay, in the first decade after the diagnosis of the SLE, along with infection, your lupus nephritis is the most common cause of mortality. And what is the mainstay of treatment for lupus nephritis is you need to start with high dose steroids. That is IV methylprednisolone should be given. And followed by this IV methylprednisolone, the other immunosuppressive agents that you need to add is either you can give mycophenolate mofetil, or you can give azathioprine, or you can give cyclophosphamide. These are the alternative drugs that you need to give for your lupus nephritis. Okay, it is not just only methylprednisolone for lupus nephritis. They also require your azathioprine or cyclophosphamide or your mycophenolate mofetil. Okay, so that is about your lupus nephritis, right? Now, so this completes the discussion of the very important topic, the systemic lupus erythematosus. Then, okay. Now, let us just take up the discussion of the next important topic in the connective tissue disorder, that is your rheumatoid arthritis. Okay. Now, you answer this question. Okay, yes. In this case, cyclophosphamide we cannot give, but if there is no hemorrhagic cystitis, then we give cyclophosphamide. Okay. In long-standing rheumatoid arthritis, which will be seen? Milk alkali syndrome, nephrolithiasis, paradoxical aciduria, secondary amyloidosis. Anyone? Paradoxical aciduria, na? Right. So what you see in a long-standing case of rheumatoid arthritis, very good, Rahul Guraha. So the answer is the secondary amyloidosis, right? Because your rheumatoid arthritis, it is a chronic inflammatory pathology, right? And your AA form of amyloidosis, right, which is nothing but your reactive amyloid A, or of most severe complication of your rheumatoid arthritis. This is one of the life-threatening complication of your rheumatoid arthritis. Which one? The development of amyloidosis. And that too, which form of amyloidosis? That is AA amyloid is being formed in patients with the rheumatoid arthritis. And you take this milk alkali syndrome, right? Very good, Munshi. You are excellent, Munshi. So milk alkali syndrome. So can anyone tell me milk alkali syndrome occurs due to abuse of which particular drugs? Yes, due to abuse of which particular drugs will result in the milk alkali syndrome? It is calcium containing antacids. Right? Yes, very good, Shambhunath and as well as Chiranjeev. So calcium containing antacids are the one which will predispose to the development of your milk alkali syndrome. All right. Now, let us discuss few points about your rheumatoid arthritis. So rheumatoid arthritis, this is an autoimmune disorder, right? It is an autoimmune disorder where the inflammatory cells, they infiltrate into the joint and will cause the destruction of the joint. Okay. So you have erosions in case of the rheumatoid arthritis. Now, can anyone tell me what is the type of HLA in patients with the rheumatoid arthritis? Yes, what is the type of HLA that you will have in patients with rheumatoid arthritis? Any one of you? Yes. Chiranjeev, it is your HLA-DR4. HLA-DR4. Okay. It is not HLA-DR3. Right? And what is that condition where you have HLA-DR3 and as well as HLA-DR4? What is that condition where you have HLA-DR3 and as well as HLA-DR4? Yes, Chiranjeev. You see that in case of type 1 diabetes mellitus, you have HLA-DR3 and as well as the HLA-DR4. All right. Next. Now, in patients with rheumatoid arthritis, which joints are commonly affected? The joints which are commonly affected are the small joints, right? And what are those small joints which are commonly affected? The small joints which are commonly affected are proximal interphalangeal joint, metacarpophalangeal joint, and metatarsophalangeal joint. Okay, and you don't have the involvement of the distal interphalangeal joint, right? And these patients with rheumatoid arthritis on long standing, they develop the deformities. Okay, now what are the deformities? Okay, but first of all, tell me in which condition your DIP is involved, in which condition your distal interphalangeal joints are commonly affected, right? Distal interphalangeal joint. Yeah, Shambhunath, that is what I am trying to do, Shambhunath. Yeah, in distal interphalangeal joints, they are affected in case of the osteoarthritis and as well as the psoriatic arthritis, right? Psoriatic arthritis. All right. Now, at the same time, you need to be very much aware of the deformities that you will have in these patients. So the deformities that you will have in patients with long-standing rheumatoid arthritis is your Botany's deformity, and the other one is the Swan neck deformity, which you commonly come across in patients with the rheumatoid arthritis. And in case of your Swan neck deformity, you have the hyperextension in the proximal interphalangeal joint, right? And you have the flexion in the distal interphalangeal joint. Whereas in Botany's deformity, it is exactly opposite. You will have the flexion in the proximal interphalangeal joint and extension in the distal interphalangeal joint. Okay. So these are the deformities. And the next important deformity that you will have is your Z-line deformity. And that is due to subluxation of your metacarpophalangeal joint that will result in the Z-line deformity within the thumb. Okay. And next important abnormality will be the ulnar deviation, right? The another important abnormality will be in the form of the ulnar deviation. Okay, so these are the deformities that you will have in patients with the rheumatoid arthritis. Now, and at the same time, you need to be very much aware of the involvement of the spine. So can anyone tell me which part of the spine is commonly affected in patients with rheumatoid arthritis? Yes. Which part of the spine is commonly affected in patients with the rheumatoid arthritis? Anyone? Very good, Pratyusha. So it is the cervical spine which is very commonly affected. Okay. And that too, which part of the cervical spine? That is your C1 and as well as, okay. So that will be C1 and as well as the C2 vertebra, which are commonly affected. That is your atlantoaxial joint dislocation, right? Atlantoaxial joint dislocation. That is what is being affected in patients with rheumatoid arthritis. And because of atlantoaxial joint dislocation, the individual will have pain in the cervical area, and that will be radiating to the occiput. And because of your atlantoaxial dislocation, these patients will also have quadriparesis. These patients will also have quadriparesis in case of your and that too spastic quadriparesis. And they also have the sensory abnormalities as well in these patients with the atlantoaxial dislocation. All right. And how will you diagnose that there is atlantoaxial dislocation is you need to do MRI of the spine, right? Or you need to do the C-spine X-ray, right? You need to do C-spine X-ray. Okay. And the next important is the dens of the axis. It can protrude upwards, compressing the brainstem. And the dens of the axis, when it protrudes upwards, compressing the brainstem, then these patients can have the respiratory arrest and cardiovascular collapse also. And in patients with rheumatoid arthritis, please remember, you also have extra-articular manifestation. So what is the most common extra-articular manifestation? Yes. What is the most common extra-articular manifestation that you will have? Anyone? So the most common extra-articular manifestation, yeah, so that will be in the form of the subcutaneous nodules. That will be in the form of your subcutaneous nodules. And these subcutaneous nodules, they are like painless, right? And where are they observed? They are observed over the extensor surface of the forearm. That will be your the most common extra-articular manifestation. And you also have pulmonary manifestation in patients with the rheumatoid arthritis. And what will be that pulmonary manifestation? That will be in the form of the pleural effusion. And that too, what type of pleural effusion? Exudative type of pleural effusion will be there. And followed by that, these patients will also have necrobiotic nodules. Okay, so can anyone tell me what is that? Kohlwerker's pneumoconiosis plus your rheumatoid arthritis. What is this syndrome called as? Yes, Kohlwerker's pneumoconiosis plus rheumatoid arthritis. What is this particular syndrome called as? Right. Very good, Multani. So that is nothing but your Kaplan syndrome. Right. This is nothing but your Kaplan syndrome. And in patients with your rheumatoid arthritis, you also have the presence of what is called Felty's syndrome. So can anyone tell me what is a triad that you will have in Felty's syndrome? Yes. What is a triad that you will have in patients with the Felty's syndrome? Anyone? In the Felty's syndrome, you will have rheumatoid arthritis, and along with that, you have splenomegaly, and along with that, you also have the neutropenia, right? Neutropenia. So this is what is your Felty's syndrome that you come across in patients with the rheumatoid arthritis. And in patients with rheumatoid arthritis, you also have ocular involvement, and this ocular involvement will be in the form of your scleritis, right? And as well as the Sjogren syndrome. This will be the ocular manifestation. And these patients also have the neurological manifestation. And that too, that is peripheral nervous system involvement will be very common. And what will be that peripheral nervous system involvement very common is, one is your tarsal tunnel syndrome, where there is compression of the tibial nerve, and carpal tunnel syndrome, where there will be compression of the median nerve, right? Where there will be compression of the median nerve. And finally, what is the cause of death in patients with rheumatoid arthritis? Yes, what is the cause of death in patients with the rheumatoid arthritis? Yes, what is the cause of death in patients with the rheumatoid arthritis? Okay, so the cause of death is not pericardial effusion. Actually, yes, if you take this X-ray, this is suggestive of your pericardial effusion. But the cause of death in these patients will be like coronary artery disease. These patients will develop what is called premature atherosclerosis causing coronary artery disease, where these patients can develop a myocardial infarction and as well as death of the individual. And what are the other features that you will have in these patients is there can be development of the pericardial effusion also, right? So this is about your cardiac involvement. Now you should know the workup, that is investigation. So what is the investigation of choice in patients with rheumatoid arthritis? What is the investigation of choice in patients with rheumatoid arthritis? So investigation of choice in patients with rheumatoid arthritis will be your anti-CCP, right? Anti-CCP. That is the investigation of choice in patients with the rheumatoid arthritis, right? And at the same time, you need to be very much aware of like what does the X-ray of the joints will show. X-ray of the joints in patients with rheumatoid arthritis will show you the presence of the periarticular osteopenia, right? Periarticular osteopenia, and even the joint space in patients with rheumatoid arthritis will be reduced. Okay, joint space will also be reduced. Okay, and RA factor will be positive, but this RA factor which is positive, it is non-specific. All right. Now coming to the treatment, what is the drug of choice in acute cases of rheumatoid arthritis? What is the drug of choice in acute cases of rheumatoid arthritis? Any one of you? Not NSAIDs. NSAIDs are not the drugs that we give in acute cases. So it is your no. In acute cases, Multani, it is not methotrexate which will respond, because methotrexate it will take almost like 2 to 4 weeks for the onset of its action, right? The drug of choice in acute cases will be the steroids in case of rheumatoid arthritis, whereas the drug of choice in patients with rheumatoid arthritis in long-standing cases, that will be your methotrexate. right? That will be your methotrexate. Okay, so methotrexate is considered as the DMARD, disease modifying anti-rheumatic drug, and it is a non-biological DMARD. And it is a non-biological DMARD. All right, so this is about your rheumatoid arthritis story. Now, yes, answer this. A 24-year-old female presents with the abdominal pain, hematuria, and arthralgia. On examination, palpable purpuric rash was seen on the trunk, limbs, and buttocks. Coagulation tests were normal. What is the most probable diagnosis in this patient? Hemolytic uremic syndrome, Heenan-Sjölin's purpura, meningococcemia, thrombotic thrombocytopenic purpura. Right, very good. So this is suggestive of your HSP, that is your Heenan-Sjölin's purpura. So Heenan-Sjölin's purpura is what? It is a form of small vessel vasculitis. Can anyone tell me what is another name of the Heenan-Sjölin's purpura? What is another name for Heenan-Sjölin's purpura? Any one of you? So the another name for Heenan-Sjölin's purpura, this is also called as, right, this is also called as, very good, it is also called IgA vasculitis. IgA vasculitis. And the features of your Heenan-Sjölin's purpura, you can just remember in a form of a tetrad, that is HSP. You can just remember in a form of a tetrad, that is called HSP. H, it stands for hematuria, because you have the involvement of the kidney in the form of glomerulonephritis. Skin involvement will be there, and that skin involvement will be in the form of the purpura, right? Now, one point you have to remember is the purpura, whichever is there, is not because of thrombocytopenia. The purpura that you have in these patients, this is mainly because of the cutaneous vasculitis. Right? It is because of the cutaneous vasculitis, you have the presence of the purpura. Okay. And the last P, it stands for pain in the joints and as well as the abdomen. So this is a tetrad that you will have in patients with the Heenan-Sjölin's purpura. What is the investigation of choice? Investigation of choice is you need to do the skin biopsy. The skin biopsy will show you the presence of IgA, that is your IgA vasculitis. Okay. Now, what is the drug of choice in patients with the Heenan-Sjölin's purpura? Anyone? What is the drug of choice in patients with the Heenan-Sjölin's purpura? Right? Yes. So we give the prednisolone. So steroids, they are the drug of choice in patients with the Heenan-Sjölin's purpura. And you take this purpura, where is it being distributed very commonly in patients with your HSP? The purpura, it is like palpable purpura, right? The purpura will be like palpable purpura. Okay, that is mainly distributed over the lower limbs, that is extremities, and as well as the trunk. Right, this is where you have the purpura. And yes, Heenan-Sjölin's purpura is characterized by deposition of the following immunoglobulin around the vessel. Following immunoglobulin around the vessel. Very good. So it is your IgA. Okay, and that is the reason why it got its name, the IgA vasculitis, which is a form of small vessel vasculitis. Now tell me, your Heenan-Sjölin's purpura, right? Is it seen only in children, or is it seen only in adults, or is it seen both in children and adults? Yes. Very good, Chiranjeev. So it is seen in both, right? But if the question is asked, what is the most common cause of vasculitis in children? Then the answer should be your Heenan-Sjölin's purpura. All right. And what is the most common cause of vasculitis in adults? Not Kawasaki, Chiranjeev, not Kawasaki. It is your Heenan-Sjölin's purpura. That is the most common cause of vasculitis in children. And followed by Heenan-Sjölin's purpura, it is your Kawasaki. Okay, right. And in adults, what is the most common cause of vasculitis? It is not giant cell arteritis. The most common cause of vasculitis in adults will be idiopathic cutaneous vasculitis. right? Idiopathic cutaneous vasculitis, okay, that is the most common cause of vasculitis in adults. All right, so this is about your small vessel vasculitis, Hino and Schollen's purpura. Okay, now let me take up the discussion of your scleroderma, which is also called systemic sclerosis. Yeah, all are true about the scleroderma crisis except yes, all are true about the scleroderma crisis except accelerated hypertension, onion skinning of renal vessels. Anti-centromere antibody is a positive predictor of the disease. ACE inhibitors reduce the mortality rate in patients with the scleroderma, which is the incorrect statement. Yes. So the incorrect statement is no, you have the onion skinning of the renal vessels in patients with scleroderma renal crisis, and that is due to accumulation of the fibrous tissue within the renal vasculature, right? And what is that you don't have? I mean, which is the incorrect statement is the anti-centromere antibody is a positive predictor is a wrong statement. Okay, the presence of your anti-centromere antibody, it is the negative predictor. It is not a positive predictor. Okay, now you take this scleroderma renal crisis or scleroderma crisis. It is present in almost 12% of patients with the scleroderma, right? And what happens in scleroderma crisis or scleroderma renal crisis is you have renal artery stenosis, right? Within the renal artery, you have the accumulation of the fibrous tissue. And the fibrous tissue which is accumulated in the renal artery will cause the renal artery stenosis. And thereby what will happen to renal perfusion? Renal perfusion decreases and there will be activation of RAS and that will result in the accelerated hypertension, right? And this accumulation of the fibrous tissue on cut section, you will observe the onion skinning of the renal vessels. And now, like the hypertension, whatever you're having is mainly because of the excessive activation of RAS. So how can you inactivate the RAS? That is by giving the ACE inhibitors. So ACE inhibitors will reduce the mortality rate in patients with the scleroderma renal crisis. All right. Okay. So next question. Right. A woman of 30 years presents with Raynaud's polyarthritis dysphagia of 5 years and sclerodactyly. On workup, anti-centromere antibody is positive. So what do you think is the likely cause in this patient? Very good. So, right. So it is the case of your CREST syndrome, right? Which is nothing but C stands for calcinosis, R is your Raynaud's phenomena, E is your esophageal dysmotility, S stands for sclerodactyly, and T stands for telangiectasia, right? Now, so in CREST syndrome, which is nothing but a form of localized scleroderma, right, which is a form of localized scleroderma, you have anti-centromere antibody. Now, can anyone tell me what is the antibody that you will have in case of the diffuse scleroderma? What is the antibody that you will have in case of diffuse scleroderma? Any one of you? In case of diffuse scleroderma, the antibody that you will have is very good. That is your anti-topoisomerase antibody, which is also called as your anti-SCL70, right? Anti-SCL70. Now you take in case of the mixed connective tissue disorder. So can anyone tell me what is the antibody in case of the mixed connective tissue disorder? Antibody in the mixed connective tissue disorder. That will be your anti-U3-RNP, right? Anti-U3-RNP. Okay, right. Then you take the SLE. So in case of SLE, like what will be the antibody? In case of the SLE, the antibody will be your anti-Smith, right? Anti-Smith, like which is the most, right? Which is the most specific. Whereas your anti-dsDNA will be most sensitive. I'm sorry. The anti-dsDNA is the one which will tell you about the severity of the disease. And your anti-nuclear antibody is like most sensitive in case of your the systemic lupus erythematosus. Whereas the antibody in case of your rheumatoid arthritis will be your anti-CCP, that is cyclic citrullinated polypeptide. All right. So that was about your CREST syndrome. Okay. All of the following are the features of the scleroderma except. Yeah. Yes, Munshi. The questions what I am asking you, they are like the PYQs in the FMGE exam. They're all these whatever I'm asking you are PYQs, and some additional questions like clinical questions I have added up. Okay. Right. So all of the following are the features of the scleroderma except is your diffuse periosteal reaction. Diffuse periosteal reaction is not the feature of your scleroderma, right? Whereas esophageal dysmotility will be there. That is because of the accumulation of the fibrous tissue within the esophagus, right? And the erosion of the tip of the phalanges will be there, and that we call it as the sclerodactyly. This we call it as sclerodactyly. And lung infiltrates, if you observe, lung involvement is usually seen as diffuse and bilateral. Right, diffuse and bilateral, and that too, there will be basilar reticulonodular infiltrates. Okay, so that is what you will have in patients with the scleroderma, right? Your infiltrates are nothing but that will be in the form of your interstitial lung disease. And you don't have diffuse periosteal reaction. Okay, what is that you will see within the X-ray is that is in the bone changes in the scleroderma. The bone changes in scleroderma will be in the form of acroosteolysis, right? In the form of acroosteolysis, and there will be also periarticular osteoporosis. Right, there will be also the periarticular osteoporosis, and as well as the joint space narrowing is what you will observe, right? So this is about your scleroderma important question. Okay, this is another important PYQ which was asked on scleroderma. Screening test for scleroderma is yeah, screening test for scleroderma is right. So I know many of you will answer it as the anti-topoisomerase antibody, but anti-topoisomerase antibody is not the answer. Anti-topoisomerase antibody is not a screening test. It is a diagnostic test. It's a confirmatory test for your scleroderma. Understood? The right, very good. So only Pratyusha has answered it. Very good, Pratyusha. So it is anti-nuclear antibody, which is a screening test for the scleroderma. So screening test anti-nuclear antibody is used in many clinical conditions. What are all the clinical conditions where we use the anti-nuclear antibody as a screening test is systemic lupus erythematosus, mixed connective tissue disorders, Sjogren syndrome, scleroderma, CREST syndrome, rheumatoid arthritis, polymyositis, and dermatomyositis. In all these connective tissue disorders, like we use the anti-nuclear antibody as a screening test. All right. Okay. Now, all are the X-ray findings of the scleroderma except all are the X-ray findings of the scleroderma except which of the following is not the X-ray finding of the scleroderma? Yes. See, this is actually a repeat question. No, you should not do a mistake in this question. Just now we have discussed now in patients in the X-ray of the bone, in patients with scleroderma, you don't have subperiosteal elevation. What is that? You will have acroosteolysis. There will be periarticular osteoporosis, and there will be joint space narrowing. That is what you will observe in the X-ray of the bone, right? Whereas if you take the X-ray of the GAT, you will notice that there is dilatation. Why there is dilatation? Because there is fibrosis of lower esophageal sphincter, and because of which there is dilatation due to aperistalsis of the esophagus. And pseudo obstruction will be there. Why there is pseudo obstruction? Again, it is because of the accumulation of the fibrous tissue within the gastrointestinal tract. And pneumatosis intestinalis can be observed in the X-ray. What is that? Because of the pseudo obstruction, right? Or because of the accumulation of the fibrous tissue within the gastrointestinal wall, the absorption across the GAT will be reduced. So the food which is not absorbed in the GAT across the intestine will be acted upon by the intestinal flora, and where there will be excess amount of the gases. So there is excess gaseous accumulation within the intestine because of the fermentation by the gut flora, and that is what will result in what is called as pneumatosis intestinalis. The word pneuma is nothing but air. Intestinalis, that is within the intestine. All right. And because of this, your dilatation, I mean, that is due to accumulation of the fibrous tissue within the lower esophageal sphincter. These patients, they will have GERD, gastroesophageal reflux disease will be there in these patients. All right. Now I'll just show you an image. Yeah. So please tell me in which disorder you get this particular feces, right? Very good. So you get this in, so this is like pinched mouth. Okay. This is nothing but the pinched mouth. You get this in case of the scleroderma, not in Sjogren's. You get this in case of the scleroderma. And you see that puckering of the skin. And that is mainly because of the accumulation of the fibrous tissue within the skin, right? Then, yeah, this is another important image which is very, very important. So on exposure to the cold, initially the individual will have the pale color over the digits, and later you will have cyanosis, and later you will have the red color. So what is this? This will be your Raynaud's phenomena. And when you come across this Raynaud's, that is in patients with the scleroderma, you have this Raynaud's. Okay, and that paleness is mainly because of the accumulation of the fibrous tissue around the digital blood vessels, and the cyanosis is mainly because of decreased oxygenation and increase in the quantity of reduced hemoglobin that will result in the cyanosis. And the redness is mainly because of the reflex vasodilatation. Redness is due to reflex vasodilatation causing the redness of the digits. Okay. And within the scleroderma, you have this what is called the sclerodactyly, where the tip of the digits you have the ulceration. And in patients with scleroderma, you also have this classical sign. Can anyone tell me what is the differential diagnosis of this particular sign? In which endocrine disorder you get this sign? Yes, in which endocrine disorder you get this particular sign? Yes, yeah, this is called as the prayer sign. And the endocrine disorder where you get this prayer sign will be in cases of diabetes mellitus, not in acromegaly. That is called diabetic chiropathy. Very good, Kranti Reddy. And you get this prayer sign also in patients with scleroderma. That is because of accumulation of the fibrous tissue within the skin, right? So this is what is called prayer sign. Now, in patients with scleroderma renal crisis, we give ACE inhibitors. But in patients with scleroderma as such, what is the treatment in scleroderma? You need to give steroids, that is prednisolone. Okay, so this is about the discussion related to your scleroderma. And let me discuss one more important form of vasculitis. Yeah, Kawasaki's disease is associated with all of the following features except erythema, posterior cervical lymphadenopathy, thrombocytopenia, conjunctivitis. Right? Yes, very good, Pratyusha. So these patients with Kawasaki, like what exactly is this Kawasaki? It is a form of a medium vessel vasculitis. It is a form of medium vessel vasculitis. And in patients with Kawasaki, what is that you will have is thrombocytosis will be there. Right? Thrombocytosis will be there, but not thrombocytopenia. Whereas the other features like erythema, posterior cervical lymphadenopathy will be there, where the enlargement of the lymph node will be more than 1.5 centimeters. And you take this conjunctivitis, it is bilateral non-exudative conjunctivitis. Right? Bilateral non-exudative conjunctivitis that you will have. And yes, the tongue, if you observe, this description is called as the strawberry tongue. But the discussion here is it like a white strawberry or red strawberry? Yes. The strawberry that you'll have in patients with Kawasaki, is it a white strawberry tongue or is it a red strawberry tongue? Yes, yes, very good, Pratyusha. So you get this white strawberry tongue. Now the question comes, where do you get this red strawberry tongue? Anyone? Where do you have this red strawberry tongue? Hmm? Right. So red strawberry tongue is observed in case of the scarlet fever. Okay. So scarlet fever, you have this red strawberry tongue, and this scarlet fever is caused by which particular organism? What is the organism? That is streptococcus. Okay, that is your streptococcus. Okay, so that is about your scarlet fever. And even you get this rash in patients with scarlet fever, and that rash we describe it as the sandpaper consistency. The rash that you have is the sandpaper consistency. And at one point you need to know all these particular strawberries. At one point you need to know all these strawberries. So where is that you have this strawberry nose? Where is that you'll have this strawberry nose? That is in patients with rhinosporidiosis. Okay. Then where is that you have the strawberry gums? Strawberry gums, you come across this in case of, or strawberry gingiva. Yeah, you get this in case of Wegener's granulomatosis. Okay. Then what is that condition where you have the strawberry cervix? Right, strawberry cervix. The strawberry cervix that you will have in case of your trichomoniasis. Right, trichomoniasis. And finally, where is that you have this strawberry gallbladder? Strawberry gallbladder. Strawberry gallbladder is observed in case of the cholesterolosis. Okay, it is observed in case of the cholesterolosis. Okay, and finally, what is the drug of choice for Kawasaki disease? What is the drug of choice for Kawasaki disease? Anyone? So Kawasaki's is what? It is a form of medium vessel vasculitis. Right. So it is the intravenous immunoglobulin. Intravenous immunoglobulin, that is a drug of choice in patients with your Kawasaki disease. And what is the vessel that is like very commonly affected in Kawasaki is the coronary artery. Right. So there can be coronary artery aneurysm. Right. The coronary artery aneurysm. Okay. Right. Yes. Along with your intravenous immunoglobulin, we also give a low dose aspirin. We also give low dose aspirin. That is mainly to prevent the thrombus formation. Okay, so that was about your Kawasaki, which is a medium vessel vasculitis. Now, let me discuss about the Takayasu, which is also a large vessel vasculitis. Right, and what is another name for this Takayasu? Yeah, most common variant of Takayasu in India. And what is another name for the Takayasu? It is not giant cell arteritis. No. It is not temporal arteritis. Right. The another name for this is, right, who is that? Yes, very good, Vidya. So this is also called as the pulseless disease. Right. Or it is also called iotoarteritis. It is also called iotoarteritis. Okay. Yeah. Can anyone just make a guess? The most common variant of Takayasu in India? Most common variant of Takayasu in India? Type 1, 2, 3, 4. So the most common variant of Takayasu in India will be your type 3. Type 3 is the most common. And at the same time, you should also be very much aware of what is the most common vessel which is affected in Takayasu. The most common vessel which is affected in patients with Takayasu will be the subclavian artery. And once there is inflammation of the subclavian artery, what will happen? The blood supply, the blood supply to your brachial artery, axillary artery, and as well as radial artery will be reduced. So thereby, the pulse within the radial artery will be reduced. And that is the reason why this is called as the pulseless disease. That is the reason why it is called pulseless disease. Okay. Now you take the variants. You have totally five variants: type 1, 2, 3, and as well as 4. You take in case of type 1. In case of type 1, you have the involvement of the arch of aorta. Okay. Whereas in type 2, in case of type 2, it is the involvement of thoracoabdominal aorta and its branches, right? Without involving the aortic arch. So you have the involvement of the thoracic aorta, and you also have the involvement of the abdominal aorta in case of your type 2. There is no involvement of the arch. Then what is your type 3? Type 3 is what is more common in India. Type 3 is what is more common in India, where you have the involvement of both type 1 and as well as type 2 together is called type 3. What is type 4? Type 4, you have pulmonary artery involvement along with type 1, 2, or 3. And type 5, you have the involvement of the coronary artery along with type 1, 2, or 3. So this is about that variants of your Takayasu. The one which is more common in India will be your type 3. Now, another name for your Takayasu, it is also called as reversed coarctation of aorta. So can anyone tell me why is it called reversed coarctation of aorta? Yes. Why is it called reversed coarctation of aorta? Why is it called reversed coarctation of aorta is because you take in case of the coarctation of aorta, the most common site of coarctation will be your distal to left subclavian artery. Right, distal to the left subclavian artery. So in case of coarctation of aorta, what is that you have to remember is your lower limb blood pressure will be more than compared to that of the upper limb blood pressure in case of coarctation of aorta. Whereas in case of your Takayasu arthritis, where there is the inflammatory destruction, the upper limb blood pressure, I'm sorry, I exactly said ulta, I'm very sorry. So in case of your coarctation of aorta, the upper limb pressure will be more than compared to that of lower limb pressure. Whereas in your Takayasu arthritis, which is nothing but reversed coarctation of aorta, the upper limb pressure will be less than compared to that of lower limb, or lower limb pressure will be more than compared to that of the upper limb. Okay, so that is why it is called as the reversed coarctation of aorta. All right, so this was about your Takayasu, and at the same time, you need to know what is the investigation of choice. The investigation of choice in patients with your Takayasu will be MRI of the aorta. That will be the investigation of choice. All right. Then you need to know the treatment in patients with your Takayasu. Yeah, please answer. Came to the emergency complaining of unilateral. No, this is like the other one. Okay. So the treatment in patients with your Takayasu will be your steroids. Okay. That is your prednisolone is what you need to give. Right. Coming to the next question. A 50-year-old male came to the emergency department with complaints of the unilateral headache, diplopia, and difficulty in chewing the food. On evaluation, MRI was normal. The ESR was persistently high, right? And the most appropriate drug for the treatment. Right. So can anyone tell me what is the nine? Pratyusha, it is not trigeminal neuralgia. It is not trigeminal neuralgia. Yeah, very good. So this is a diagnosis of giant cell arthritis. This is a diagnosis of giant cell arthritis. Okay, so which is also called temporal arthritis. So giant cell arthritis or temporal arthritis, what is the drug of choice is your prednisolone. And what are the points to tell it is giant cell arthritis is first age of the individual. Age of the individual in case of your giant cell arthritis, it should be more than 50 years. That is the first important thing. And usually these patients with giant cell arthritis, they present with unilateral headache. And why is that unilateral headache? That is because of the inflammation of the temporal artery, which is a branch of the external carotid artery. And why is that these patients will present with diplopia? The diplopia is mainly because of the involvement of ophthalmic artery in patients with giant cell arteritis. Okay, and because it's an inflammatory pathology, when you do ESR will be elevated. The ESR will be elevated. And in patients with your giant cell arteritis or temporal arteritis, what is very important is the investigation of choice. Can anyone tell me what is the investigation of choice? Yeah, very good, Kranti Reddy. These patients will also have jaw claudication. Why is that? But that is because of decreased blood supply to the muscles of mastication, that is medial pterygoid, lateral pterygoid, masseter, and as well as the temporalis muscle. Yeah, investigation of choice. Very good. So you need to do a temporal artery biopsy. Yeah, what does the biopsy show? Yes, what will the biopsy show? Anyone? What will the biopsy show? Yeah, biopsy will show you the presence of granulomatous inflammation, right? Granulomatous inflammation. But whenever you take the biopsy, how many centimeters of the vessel you will take the biopsy? How many centimeters of the vessel you will take the biopsy? And why is that you take that much centimeters? Both of these you should answer me. Yeah, so it is around 2 centimeters, right? Yeah, so yes, Pranav Mohanan and as well as Multani, please tell me why is that? Yes, very good, Pranav Mohanan. It is because of the presence of the skip lesions. It is because of the presence of the skip lesions. You need to take the biopsy for up to 2 centimeters. All right. So this is about the giant cell arteritis, which is also called temporal arteritis. Yeah. Next question. A patient presents with melena, normal renal function, hypertension, and mononeuritis multiplex. So what is the most probable diagnosis in this patient? Right, very good, Kranti Reddy. So the answer is the polyarteritis nodosa. The answer is polyarteritis nodosa. So what are the points in favor of your polyarteritis nodosa is multiple organ involvement, GIT involvement in the form of melena, right? Hypertension is there and mononeuritis multiplex is also there. Now, what will be the cutaneous manifestation in patients with polyarteritis nodosa? What will be the cutaneous manifestation in patients with polyarteritis nodosa? The cutaneous manifestation in patients with the polyarteritis nodosa, that will be in the form of livido reticularis, right? So livido reticularis, it is like the cutaneous blood vessels. That is due to obstruction of the dermal blood vessels, you get this livido reticularis. And this livido reticularis is mainly observed over the extremities. And what will be the peripheral nerve involvement? The peripheral nerve involvement will be in the form of the mononeuritis multiplex. That will be the peripheral nerve involvement. And what will be the GIT involvement? The GIT involvement, that will be in the form of mesenteric vasculitis. And because of this mesenteric vasculitis, these patients will have the abdominal pain. These patients will have abdominal pain and as well as gastrointestinal bleeding in the form of the melena. Now the question is, which particular virus is associated with your polyarteritis nodosa? Which particular virus is associated with the polyarteritis nodosa? Anyone? Very good, Pranav Mohanan. That is your hepatitis B. Okay, so hepatitis B, it is an established etiological agent and it has a strong association for polyarteritis nodosa. Okay, and these patients, they have the renal vasculitis, and because of this renal vasculitis, they develop renovascular hypertension. Right, they develop renovascular hypertension. Okay, right, and glomerular vessels, they are not affected. There is no glomerulonephritis in patients with the polyarteritis nodosa. And the other structures which are affected in polyarteritis nodosa is your joints and all will be affected. And ultimately, the treatment will be in the form of your steroids. Okay, next question. A 20-year-old woman presents with bilateral conductive deafness, palpable purpura on the legs, and hemoptysis. Radiograph of the chest shows a thin-walled cavity in the left lower zone. Investigation revealed total leukocyte count of 12,000 cells per cubic millimeter, RBC cast in the urine, and serum creatinine of 3 milligrams per deciliter. What is the most probable diagnosis in this patient? HSP, polyarteritis nodosa, Wegener's disseminated tuberculosis. Very good. So the answer in this question is the Wegener's granulomatosis. Okay. So Wegener's granulomatosis is like the one which is characterized by a triad where you have the involvement of the upper respiratory tract, lower respiratory tract, and the involvement of the kidney. So upper respiratory tract involvement, if you observe in this question, that is in the form of the conductive deafness. Okay, and lower respiratory tract involvement is in the form of hemoptysis and presence of thin walled cavity in the left lower zone. And the kidney involvement, that is in the form of the RBC cast in the urine, that is your glomerulonephritis. Okay, so this will be your triad that you have in patients with the Wegener's granulomatosis. Now, can anyone tell me what is the characteristic nose in patients with Wegener's? Yes, what will be the characteristic nasal abnormality in Wegener's? Very good, Chiranjeev. So you have this characteristic saddle nose deformity, right? And why is this particular saddle nose deformity? The saddle nose deformity, it is mainly because of collapse of the nasal bridge, right? The nasal bridge, whatever is there, is like collapsed. And that is the reason why you have this saddle nose deformity. And right, yes. What will be the right? What will be the gums? What is the description of the gums in these individuals? The description of the gums will be in the form of yeah, strawberry gingiva. Strawberry gingiva. That is what you will have in patients with a Wegener's granulomatosis, right? And what is the investigation of choice in patients with Wegener's? What is the investigation of choice in patients with Wegener's? Anyone? Very good. That is C. Anka. C. Anka is the investigation of choice in patients with the Wegener's. And finally, how do you treat Wegener's? The treatment will be in the form of your steroids. Okay. For almost all the forms of vasculitis, it is the steroids which will be the mainstay of treatment, right? So that finishes your Wegener's granulomatosis. Yeah. This elderly male came with a history of recurrent attacks of pain and swelling in the great toe in the past. This is present X-ray of the hands. The diagnosis can be confirmed by. Okay. So can anyone tell me what is the diagnosis? What is the diagnosis? Anyone? It is not psoriatic arthritis, Pratyusha. It is not psoriatic arthritis. Right? Very good. So the diagnosis is your gout. So what is that you are observing over the X-ray? Right? So over the X-ray, it is the presence of the eccentric juxta-articular. Okay. So it is the presence of, yeah, you can see this. Right? It is the presence of the juxta-articular in the sense surrounding the joint. Juxta-articular lobulated soft tissue mass. Right? Lobulated soft tissue mass. And where do you observe this? This lobulated soft tissue mass, these particular features are suggestive of the chronic gout. Right? These features are suggestive of your chronic gout. Okay. And in patients with chronic gout, actually in case of gout, the most common joint that will be affected is your metatarsophalangeal joint. Okay. That is the first joint or the most common joint which is being affected in patients with your gout or gouty arthritis. Okay. And followed by this MTP, what are the other joints which can get affected? The other joints which can get affected is there can be involvement of the ankle. There can be involvement of the wrist. Right? There can be involvement of the finger joints. Right? And there can be also involvement of the knee. Okay. So these are the joints which are affected in patients with your gout or gouty arthritis. And in patients with your gout or gouty arthritis, how can you confirm the diagnosis? By doing arthrocentesis. You need to take out the synovial fluid and you need to examine under the microscope. So whenever you do an arthrocentesis, you will observe needle-shaped monosodium urate crystals. And that too, that monosodium urate crystals will be like negatively birefringent crystals. Negatively birefringent crystals. Now, what is the condition where you have the presence of positively rhomboid shaped crystals. Yes. Where is that? You will have the presence of positively birefringent rhomboid shaped crystals. Yes, that you have in patients with the pseudo gout. That you have in patients with the pseudo gout. So in patients with your gout or gouty arthritis, your estimation of the uric acid, that is not the investigation of choice. It is the arthrocentesis, which is the investigation of choice in patients with your gout or gouty arthritis. So tell me, in your gout or gouty arthritis, is it possible to have the serum uric acid level being normal? Yes. Is it possible to have the serum uric acid being normal? Yes, very good, Kranti Reddy. There can be normal. In which scenarios you can have normal? In cases of acute gouty arthritis, you can have the serum uric acid levels being normal. How is it possible? How is it possible? Because the uric acid which is present in the peripheral part of the blood, that will go and accumulate within the joint. Thereby, the peripheral part, the uric acid will return back to normal. So, your serum uric acid levels may be normal in acute cases of gout. That is the reason why we don't take uric acid into consideration as the investigation of choice. It is your arthrocentesis. Now, when you do an X-ray of a patient with gout, yeah. So, can anyone tell me what is the name of these erosions? What is the name of these erosions? Right. So, these are called as rat bite lesions or rat bite erosions. Okay. And because of these rat bite erosions, you have this punched out lesions. Yeah. This punched out lesions. Right. And this is what is called Martel sign. Right. Where this Martel sign is that where you have the presence of the overhanging edges. You have the presence of the overhanging edges. Now, tell me, what is the treatment in case of the acute attack of gout? Treatment in case of acute attack of gout. Anyone? Right. So in case of acute attack of gout, we give NSAIDs. And what are the other alternative drugs? The other alternative drugs in case of acute attack will be the colchicine. And if the individual is refractory, we also give steroids. Now, please tell me, what is the drug that you will give in case of a chronic gout? What is the treatment that you will give in case of the chronic gout? In patients with renal failure. See my question. Chronic gout in patients with renal failure. Anyone? Right. So we give febuxostat. Very good. Because your allopurinol, it is excreted through the kidney, whereas febuxostat, it is metabolized in the liver. So in patients with renal failure, the preferable drug will be your febuxostat. Okay. Right. It will be your febuxostat. Right. Next. Now, after having discussed about, and if the renal failure is not there, the other alternative xanthine oxidase inhibitor is what? The other alternative xanthine oxidase inhibitor is like we give the allopurinol. Just 1 minute. Yeah. Yes, I hope I'm audible and visible to all of you. Very clear. All right. So that was about right. So that was about your discussion on the connective tissue disorders. Right. So we are done with the connective tissue disorders topic. Now let us take up the neurology. Let us start with the neurology. Yeah. Answer this question. An 80-year-old female presents with progressive loss of memory. Right. Progressive loss of memory. Difficulty in recalling the names, difficulty in speech, inability to perform the desired tasks. Which of the following pathological feature is likely to be found with the neurofibrillary tangles? Okay. So we are having, so first of all, you should look for the age of the individual. That is 80 years. Okay, 80-year female, progressive loss of memory. What is the first thing that you need to consider in the diagnosis? What is the first important differential diagnosis? Very good, Pranav Mohan. So that is Alzheimer's is what you need to consider. Okay, right. And in case of Alzheimer's, what is the inclusion bodies? That will be in the form of the beta amyloid. That is amyloid beta 2 protein, which is also called amyloidopathies. Okay. Now, can anyone tell me differential diagnosis where you have the beta amyloid accumulation? Differential diagnosis for beta amyloid accumulation apart from Alzheimer's. One is your Alzheimer's disease. There is no doubt in that. But what is another condition where you have the accumulation of beta amyloid protein? Yeah, yes, Karki, I will tell you about tau protein. Just hold on. Okay, hold on. I'll tell you about tau protein as well. So you have this beta amyloid protein in case of cerebral amyloid angiopathy. In cerebral amyloid angiopathy, CAA stands for cerebral amyloid angiopathy. Okay, so there you have the another condition where you have the presence of amyloid protein. Now coming to your tau protein, which is also called taupathies. Yeah, please tell me which conditions you have this tau protein accumulation. Yes, what are the conditions where you have taupathies? So taupathies, you come across this in case of the Pick's disease. You come across this in case of the Pick's disease. The other conditions where you have this tau protein or taupathy is in cases of the progressive supranuclear palsy, PSP, right? And then CBD, corticobasal degeneration. Okay, so corticobasal degeneration. Then in case of your progressive supranuclear palsy, Pick's disease, and even in case of frontotemporal dementia, you have the accumulation of your tau protein, right? Yes, frontotemporal dementia also you have the tau protein accumulation. Then what are the conditions where you have the alpha-synuclein protein, which is also called synucleopathies? Yes, what are the conditions where you have the alpha-synuclein protein? Very good. So that is you come across in case of your Parkinson disease. That you come across in Parkinson's. Okay, so Parkinson's disease where you have the presence of Lewy bodies. Right, where you have the presence of Lewy bodies, there you have the alpha-synuclein protein, right? And you also come across this in patients with MSA, that is multiple system atrophy, which is called Scheidegger syndrome. Which is called Scheidegger syndrome. So Parkinson's and as well as multiple system atrophy, that is Scheidegger's, you have this alpha-synuclein protein. Okay. Now the next question is, in case of Alzheimer's, right? In case of Alzheimer's, which of the following structure is not affected in case of the Alzheimer's disease? Entorhinal cortex, limbic cortex, temporal cortex, lateral geniculate body. Okay. Now, Pranav Mohan, entorhinal cortex is the most common structure which is affected. The question is not affected. Not affected. In the entorhinal cortex, like you have the presence of the hippocampus. In the entorhinal cortex, you have the presence of the hippocampus and you have this amygdala interconnections. And your entorhinal cortex, it is the most vulnerable area. Okay, and next to your entorhinal cortex, the next important structure which is affected in case of your Alzheimer's will be your limbic cortex. Then followed by that, the temporal cortex, right? Yeah, so the one which is not affected in patients with your Alzheimer's is lateral geniculate body. Lateral geniculate body is usually not affected in patients with the Alzheimer's. Okay, and at the same time, you need to know the biochemical abnormalities in the Alzheimer's disease. Anyone? All of the following biochemical abnormalities are seen in case of Alzheimer's disease except. Right. So the biochemical yes, very good, Kranti Reddy. Kranti Reddy's answer is correct, and even Chiranjeev. So you will have decreased acetylcholine. You will have decreased noradrenaline, right? And you also have decreased serotonin. And you also have decreased somatostatin, right? What is that you don't have is the decreased dopamine levels. That is not the feature of your Alzheimer's disease. Your decreased dopamine is the feature of your the Parkinsonism. All right. Now, at the same time, you need to be very much aware of what is the treatment in patients with the Alzheimer's disease. Yes. Now, tell me which of the following is not the acetylcholine esterase inhibitors. Which of the following is not the acetylcholine esterase inhibitors? Yes, right. Very good. That is your memantine. So, what is the mechanism of action of memantine? If you take these three, if you take these three, right, if you take these three, they are your acetylcholine esterase inhibitors. Okay. And they are used in case of mild to moderate form of the Alzheimer's. Mild to moderate form of Alzheimer's, we use this donepezil, galantamine, and as well as rivastigmine. Whereas memantine, what exactly is the mechanism of action? Very good, Multani. That is NMDA receptor antagonist. Right? It is an NMDA receptor antagonist. Okay. And where do you give this memantine? You give this in case of moderate to severe form of the Alzheimer's. You give this in case of moderate to severe form of Alzheimer's. Okay. So this is about your story related to the Alzheimer's disease. All right. Next. Okay. One part of your cerebrovascular accidents, a patient being evaluated for aphasia is unable to repeat sentences correctly or to name the objects properly. However, the patient's speech is effortless and melodic. There are frequent errors in word choice and obvious difficulties in the comprehension. The remainder of the patient's neurological examination is normal. Damage in which area of the brain would account for this particular type of aphasia? Yes. Uh, yes, Lavanya, what is the question? Which cardiac condition leads to death without known history of blood pressure and diabetes in elders of age around 65 years? See, Lavanya, like there are multiple conditions. Okay, coronary artery disease. It can happen even without a known history of blood, diabetes and hypertension, because age 65 years itself is a risk factor for the development of your coronary artery disease. Okay, that is one thing. Second important is like arrhythmias. The arrhythmias could be due to electrolyte abnormalities like your hyperkalemia, hypokalemia, or your sodium abnormalities, calcium abnormalities, right? Sodium and calcium abnormalities, all these can cause the arrhythmias. Electrolyte abnormalities can cause arrhythmias, causing the sudden cardiac death within the individual. Okay, right. Yeah. Answering this question now. Yes, Lavanya, I hope I have answered your question. Yeah. So the answer in this question is your posterior temporal and parietal lobe, and that too dominant hemisphere. And that too dominant hemisphere. See, what is being given here is the individual is unable to repeat the sentences, and but his speech, if you observe, it is effortless and as well as melodic. So now tell me which part of, and next is there are frequent errors in word choices as well and obvious difficulties in comprehension. So what type of aphasia do you think? Yes, what type of aphasia do you think? Very good. So the type of aphasia that you see in this patient is the Wernicke's aphasia. Wernicke's aphasia. So the speech what you have is like jargon speech, right? And you have what is called neologisms, right? Neologisms. And where exactly is your Wernicke's area? Wernicke's area is present in the posterior temporal and as well as the parietal lobes. Okay, right? And what is that area that you have in the frontal lobe? What is the area that you have in frontal lobe? That will be your Broca's area. That will be your Broca's area in the frontal lobe. So whenever the Broca's area is gone, the individual will be like aphasic in the sense like okay, I come to the questions on your Broca's as well. Yeah. So answer this. Broca's aphasia is Broca's aphasia is right. So it is a non-fluent aphasia. Broca's aphasia is a non-fluent aphasia because your Broca's area, it is the motor area for the speech, right? And it is the Broca's which will give information to the laryngeal muscles. And if the Broca's is damaged, then the information to the laryngeal muscles is gone. Then the individual will have non-fluent aphasia. Now, which one is considered as the fluent aphasia? That will be your Wernicke's aphasia. That will be your fluent aphasia. And in case of conduction aphasia, which structures are damaged in case of conduction aphasia? Yes, which structures are affected in case of the conduction aphasia? Yeah, very good. That is the arcuate fasciculus. That is affected in case of conduction aphasia. Then which is your sensory aphasia? Your Broca's aphasia is a motor aphasia, which is considered as the sensory aphasia. Right? Very good, Chiranji. So that will be Wernicke's aphasia will be your sensory aphasia. All right. Now, next question. Aphasia which affects the arcuate fibers is called. Just now we have discussed. What is that? Yeah, very good. So that will be your conduction aphasia. That will be your conduction aphasia. And one more question. Fluent aphasia with preserved comprehension and impaired repetition is. The aphasia is like fluent aphasia with preserved comprehension, right? And impaired repetition. What could be this? So fluent aphasia means like what is being intact? Your Broca's area is intact. Preserved comprehension means what? Your Wernicke's area is intact. There is impaired repetition. That will be your conduction aphasia. So what is the structure that is being gone here is the arcuate fasciculus is being damaged. Right? The arcuate fasciculus is being damaged. Okay. So this is like the table, which is a nutshell of all the types of your aphasias. So in Wernicke's aphasia, the comprehension is impaired, repetition is impaired, and naming is also impaired, but the fluency will be preserved in case of Wernicke's. Whereas in Broca's aphasia, the comprehension will be preserved, the remaining everything will be impaired. Whereas in global aphasia, everything will be decreased, like comprehension, repetition, naming, fluency, everything will be decreased. And whereas in case of the conduction aphasia, your comprehension and fluency will be preserved, but your repetition is being impaired. Your naming is impaired. Okay. That is in case of your conduction aphasia. All right. So this is about the various types of your aphasias. Okay. Now, next, after having discussed about your dementia, Alzheimer's, and as well as after having discussed about the various forms of aphasia, let me discuss about the disorders related to basal ganglia. Okay. Now, tell me, which part of the basal ganglia has to be damaged for the development of athetosis? Which part of the basal ganglia has to be damaged for the development of athetosis? What is actually athetosis? It is a form of a continuous writhing movements within the fingers. Right? It is a form of continuous writhing movements within the fingers. Okay. For the development of, very good, Kranti Reddy. Kranti Reddy's answer is correct. Right? So it is your globus pallidus. The lesion should be in the globus pallidus. All right. Then you take hemibalismus. What is hemibalismus? Hemibalismus is, it is like a sudden flailing movement. Okay. It is a sudden flailing movement of the entire limb. Right? Sudden flailing movement of the entire limb. Where should be the site of lesion? Very good, Kranti Reddy and as well as Chiranjeev. So the site of lesion should be in the subthalamic nucleus. Right? Next, you take chorea. Chorea is nothing but your flicking movements in the hands, face, and other parts of the body. Basically, it's a dancing movement. So which part of the basal ganglia should be affected for the development of chorea? Which part of the basal ganglia is affected for the development of chorea? Very good. So that will be your caudate nucleus and as well as the putamen. Right, caudate nucleus and as well as the putamen. Okay, and Parkinsonism, which part of the basal ganglia is damaged? Which part of the basal ganglia is affected in patients with Parkinsonism? Very good. That will be your substantia nigra. Substantia nigra is where you will have the lesion in patients with development of Parkinson's disease. All right. Now, you answer this question. All of the following are the causes of atypical Parkinsonism except multiple system atrophy, progressive supranuclear gaze palsy, corticobasal degeneration, pseudobulbar palsy. Which of the following is not the cause for atypical Parkinsonism? Right. So the one which is not the atypical Parkinsonism is your pseudobulbar palsy. Right. So which are all included in your atypical Parkinsonism? Multiple system atrophy, which is your Scheidegger syndrome, then progressive supranuclear gaze palsy, and as well as the corticobasal degeneration. So these are the parts of your the atypical Parkinsonism. Understood? Now you see the next question. A 40-year-old man is brought to the doctor by his family for rapid intellectual decline. Examination showed fast semi-purposive movements in the hands. His father and grandfather had a similar illness. What is the diagnosis? Presenile dementia, Lewy body dementia, corticobasal degeneration, Huntington's chorea. Yes, very good. So this question, all of you are answering it correctly. That is your Huntington's chorea. Now, the next point is, what is that which is suggestive of your chorea? That is your fast semi-purposive movements in the hands. That is what is suggestive of your the chorea. Right? And Huntington's chorea, tell me, what type of inheritance is it? What type of inheritance is it? Autosomal dominant or autosomal recessive? Very good, Kranti Reddy and all of you. So it is the autosomal dominant type of inheritance, right? Now, what is the gene that is being mutated? What is the gene that is being mutated? And on which chromosome you have that particular gene? Okay, chromosome to my likh diya already. So chromosome is like chromosome 4 is being affected. And what is the gene that is being affected? It is your, yes, very good, Kranti Reddy. So it is the Huntington gene. It is the Huntington gene, like which is very commonly being affected in these patients of the Huntington's chorea. Now, how will you rule out the other options? Okay, now you take the presenile dementia. Now, in which group of individuals you have this presenile dementia? Presenile dementia is seen in Down syndrome. Okay, so in Down syndrome, you have the presence of the presenile dementia, right? Then followed by that, Lewy body dementia. Patients with Lewy body dementia, they present with hallucination, right? They present with the hallucinations, all right? And they present with delusion, and they present with dementia. This is what you'll observe in case of Lewy body dementia. And you take corticobasal degeneration, CBD. These patients with corticobasal degeneration, they have a characteristic limb. And what is that limb? That is the alien limb phenomena, right? Alien limb phenomena, which is characterized by position of the limb in the space with the patient not being aware of it. Okay, so he will position the limb in the space, but the individual is not aware of that his own limb is being placed in the space. That is what is your CBD, corticobasal degeneration. Understood? That is called alien hand syndrome or alien limb phenomena. All right. Now, can anyone tell me the description of this particular ventricles in patients with the Huntington's? What is the description of this particular ventricles? These are called, you can see these ventricles. What is the shape of this ventricle? This is called, very good, Chiranjeev. These are called as the boxcar ventricles. These are called as the boxcar ventricles. And you need to know why you get this boxcar ventricles whenever you do MRI in patients with the Huntington's disease. So that is because of the caudate atrophy, right? Because of the caudate atrophy, the shape of the ventricles will be your boxcar ventricles. Now, what is the drug of choice in patients with Huntington's disease? Yes, what is the drug of choice in patients with the Huntington's disease? Anyone? That will be tetrabenazine. Okay. So tetrabenazine, that is a drug of choice in patients with the Huntington's disease. All right. Then, so that was about your Huntington's chorea or the Huntington's disease, where the individual will have the rapid semi-purposive movements, and along with that, there will be rapid intellectual decline. Okay, and the inheritance is autosomal dominant type of inheritance, and the gene is Huntington gene, which is present on chromosome 4. And when you do an MRI, you will have boxcar ventricles, and the drug of choice will be your tetrabenazine. Okay. Now, in which patients, whenever you do EEG, you have the presence of the square wave jerks. And at the same time, let me also ask you, what is that condition where you have the presence of the square root sign? Yes, please answer both of these two questions. Okay, just give me 1 minute. I'll be back. Just only 1 minute, okay? All right. So, welcome back. So yes, where do you come across this square wave jerks? So square wave jerks in the EEG, you come across this in cases of the progressive supranuclear palsy. In progressive supranuclear palsy, you have the presence of the square wave jerks. And what is that condition where you have the presence of the square root sign? The square root sign, you come across this in patients with constrictive pericarditis, which are nothing but your the ventricular pressure changes, and that you will be able to make out by your cardiac catheterization. Okay. Now, in patients with the progressive supranuclear palsy, what all will be the features? And it is a form of atypical Parkinsonism. The features that you have in patients with the progressive supranuclear palsy is they will have rigidity, that is cogwheel and as well as lead pipe rigidity, and you have this bradykinesia. And I'm very sorry, it is not in the EEG, it is in electrooculogram. You have the presence of the square wave jerks. Now, can anyone tell me what is the MRI in patients with progressive supranuclear palsy? Anyone? What will be the MRI in patients with the progressive supranuclear palsy? Right, very good, Kranti Reddy. So it is being described as the hummingbird appearance. The description is given as the hummingbird appearance in case of the progressive supranuclear palsy. Now, what is the treatment in these patients is, as such, there is no cure for progressive supranuclear palsy. There is no cure. The treatment primarily focuses on the symptomatology and to improve the quality of the life. Okay. And you take levodopa, right? The efficacy of your levodopa in patients with the progressive supranuclear palsy, it is very much limited, right? It is very much limited. Okay. That is about your levodopa. And you can also give some dopamine agonists like pramipexole and as well as ropinirole can be given. But even then, the usage of this dopamine agonist, the efficacy is very much limited in patients with the progressive supranuclear palsy. But what is very important is the eye movement. Okay, because of that, you get that square wave jerks. So controlling the eye movement is a very, very important part of the treatment. So this requires a definite eye care specialist, and they provide the assist devices in order to ensure that this eye movement problem can be reduced. So that is about your the progressive supranuclear palsy. Now, let me discuss one more important form of atypical Parkinsonism, which is called the Shy-Drager syndrome. Yeah, anyone? All of the following are the features of your Shy-Drager syndrome, except. Okay, so what is your Shy-Drager syndrome? Your Shy-Drager syndrome is nothing but your multiple system atrophy. Answer? Yes. No. These patients with Shy-Drager syndrome, they have the autonomic insufficiency. This Shy-Drager syndrome, which is also called multiple system atrophy, this is of two types. This is of two types. One is your MSAC, that is multiple system atrophy, cerebellar manifestation. Then next one is MSAP. MSAP is nothing but where there is involvement of basal ganglia, right? That is Parkinsonism type. Okay, MSAC is cerebellar manifestations, and MSAP, like they will have only basal ganglia involvement. Whereas MSAC, in this, there will be cerebellar manifestations. Along with cerebellar manifestations, you have the involvement of the basal ganglia as well. But one important point that you have in case of Shy-Dragers is you don't have the tremors. Okay, even though there is involvement of your basal ganglia, you don't have the presence of the tremors. Resting tremors is not the feature of your multiple system atrophy, right? And autonomic insufficiency will be there, and because of this, because of which these patients will present with postural hypotension in case of the Shy-Drager syndrome. Okay. Now, what will be the MRI finding in patients with multiple system atrophy or Shy-Dragers? Yes. What will be the MRI finding? Anyone? The MRI finding will be, yes, very good, Chiranjeev. So that will be in the form of what is called as the hot cross bun sign. Right, that will be in the form of your hot cross bun sign, okay, where there is involvement of your brainstem. And what is the treatment that you will be giving in case of the multiple system atrophy is, the treatment is in the form of levodopa. But even though you give levodopa, the response is like a poor response. Right, the response will be a poor response. And these patients, I said you, there is like autonomic insufficiency. So that is nothing but autonomic insufficiency is the one which will make the individual to develop the postural hypotension. Right, postural hypotension. So how do you treat this postural hypotension? You will treat the postural hypotension by giving the mineralocorticoid, that is fludrocortisone. Right, you need to give fludrocortisone. Okay, so this is about the treatment of the postural hypotension, autonomic insufficiency in patients with the Shy-Drager syndrome. Now, like you have all these three atypical Parkinsonism, that is progressive supranuclear palsy, multiple system atrophy, and as well as the Huntington's chorea. Now, let me tell you the areas involved. Okay, and you also have like CBD, corticobasal degeneration, but that is not very, very important. So you take the area involved in progressive supranuclear palsy. That will be your superior colliculus, which is being affected. Okay. Then multiple system atrophy. You have the involvement of the brainstem, right? Or there is involvement of the pontocerebellar tracts, right? In case of multiple system atrophy. Whereas Huntington's chorea, the part which is being affected is the caudate nucleus. Now, what will be the MRI finding in all these three? In case of your progressive supranuclear palsy, you get this classical hummingbird appearance, that is because of degeneration of your superior colliculus. And multiple system atrophy due to the involvement of the brainstem, you have this classical hot cross bun sign, which I have shown you. And in caudate nucleus degeneration of Huntington's chorea, that will give you the classical boxcar ventricle shape, right? Boxcar ventricle shape. Then coming to the clinical features. So if you take the clinical features in patients with your atypical Parkinsonism, in progressive supranuclear palsy, the superior colliculus is damaged. So they will have impaired downward gaze. Yeah, vertical gaze palsy will be there, right? Impaired down gaze. And in multiple system atrophy, these patients will have autonomic insufficiency. And because of this autonomic insufficiency, these patients will present with the postural hypotension. And in Huntington's chorea, these patients will have chorea and as well as dementia. Okay, so these are the three important forms of the atypical Parkinsonism that you need to be very much aware of. Sorry. Right. Now, we'll move on to the next important topic in the neurology. Yes. Now, who is this great personality and what is this problem in this great personality related to the neurology? Hmm? Yes. Very good, Parvez. So, but who is this person, right? So, yes, I have given you this person's name here. So, he's none other than the Muhammad Ali. Right. So you see this, what he says. I hated every minute of training, but I said, don't quit. Suffer now and live the rest of your life as a champion. So even your preparation also, right? So no one loves, right, sitting in front of the books and as well as reading. So we hate every minute of our preparation, but we have to say that we should not quit, right? We have to suffer now of the preparation in by sitting in front of the books in order to have a good life in the rest of our future. Okay, so that is very, very important, right? Okay, now let me discuss about this Parkinsonism. Okay, so a 79-year-old right-handed gentleman presents to the clinic with 6 months history of the stiff right arm, which is interfering with his daily activities. His wife has noticed his voice has become quieter and his walking is slower than it was. Observing him, you notice his right hand is shaking at rest. Which drug, right? Which drug would you start in this gentleman? Yes, very good. So the diagnosis is suggestive of the Parkinsonism, right? Diagnosis is suggestive of your Parkinsonism. Okay, and the stiff right arm, the stiff right arm. So what type of stiffness that you will have in upper limbs and what is the type of stiffness that you have in lower limbs? Yes. What is the rigidity that you will have in upper limbs and what is the rigidity that you will have in the lower limbs? Yeah. So in the upper limbs, the type of rigidity is the cogwheel rigidity. Whereas in lower limbs, the type of rigidity will be your lead pipe rigidity. Okay. And the voice also, if you observe these individuals, they will have hypophonia. Why is that they have hypophonia in patients with Parkinsonism? That is because of rigidity of your vocal cords. Because of rigidity of the vocal cords, the individual will have the hypophonia, right? And walking is also slower. And what is this characteristic gait? What is this characteristic gait in these individuals? The characteristic gait that you will have in these individuals is festinate gait, okay, where the individual will have a short shuffling steps and shaking at rest. These hands are shaking at rest. What are these? These are nothing but the tremors, okay. right? These are nothing but tremors, and that too usually it is your resting tremors. So the treatment that, what is the drug of choice in patients with your Parkinsonism is your levodopa. Okay, and most of the times this levodopa is administered with your peripheral decarboxylase inhibitor. And what is that peripheral decarboxylase inhibitor? The peripheral decarboxylase inhibitor will be your carbidopa or benserazide should be given, right? Carbidopa or benserazide should be given. Okay. Cupcake, you are in the first question of uchronosis. We have almost finished 2.5 hours of the session. Okay, I'll come back to that uchronosis again. Let me finish the neurology first. Okay, right. So in the treatment of your Parkinsonism, these are all the various drugs. So we have your precursor of dopamine, that is levodopa. And then we have the dopamine agonists. And what are the examples of your dopamine agonists? That is your apomorphine, rotigotine, bromocriptine, cabergoline, pergolide, pramipexole, and ropinirole, and amantadine. Then we also have, right, it's okay. Right. We also have monoamino oxidase inhibitors and as well as the COMT inhibitors. Monoamino oxidase inhibitors are rasagiline and selegiline, and COMT inhibitors are the entacapone and as well as tolcapone. Okay. And okay, now the question is, among this entire list of drugs, what is that particular group of drugs which will reduce the tremors? Yes. What is the group of drugs that will reduce the tremors? Yes. What is the group of drugs that will reduce the tremors? Very good. That will be your anticholinergic drugs that will reduce the tremors. All right. Okay. Now, yes, Cupcake, let me answer your question. I was not understanding that word shower actually, right? Now, later it clicked me like, what was the question actually? It is not shower, it is your Schober's test. Hannah. So it was the Schober's test that is being positive. And in patients with alkaptonuria, which is causing your uchronosis, right, which is causing uchronosis, remember, there will be spine involvement in the alkaptonuria, that is uchronosis. So even in patients with uchronosis, that is alkaptonuria, you have, right, you have the Schober's test being positive. Schober's test will be positive even in case of the uchronosis as well. Okay, right. Next to this, you just see this question. Which of the following is most commonly used site for deep brain stimulation for reduced frequency of Parkinsonism symptoms? To reduce the symptoms of Parkinsonism symptoms. Striatum, globus pallidus, subthalamic nucleus, putamen. Anyone? So where is that you will place the deep brain stimulation is a question. Kranti Reddy's answer is correct. Okay, so whoever has answered C, that is the subthalamic nucleus, because in this patient your substantia nigra is damaged. Because the substantia nigra is damaged, so where is that you will place your the deep brain stimulation? The deep brain stimulation has to be done by placing the electrode within the subthalamic nucleus. Okay, that is the answer. And where do we use this deep brain stimulation is individual who is refractory to medical management, right, who is refractory to medical management. In them we use this deep brain stimulation. All right, now what is this particular sign in patients with Parkinsonism? This is a red flag sign. Yes, anyone? What is this sign? It's a red flag sign. So this particular red flag sign that you observe in patients with Parkinsonism, this we call it as the wheelchair sign of Quinn. Right, this we call it as wheelchair sign of Quinn. So in case of your wheelchair sign of Quinn, there will be complete loss of postural reflexes. The individual is not able to stand. Whenever he stands, he will just immediately fall off. And he is completely dependent to wheelchair. And that is the reason why it is called wheelchair sign of Quinn. Okay, and it's a red flag sign. That means it tells you a very severe form of Parkinsonism. right? This tells you a very severe form of the Parkinsonism. All right. Now, let me tell you some important points related to your Parkinsonism. You have the tremors, that is resting tremors. Rigidity will be like lead pipe rigidity in the lower limb and upper limb. You will have cogwheel rigidity. Postural reflexes, they are being completely lost. The individual will not be able to stand. The gait is characteristic fascinate gait. And the movements, they are like very slow. That is bradykinesia will be there. And handwriting of these individuals, they'll be very small letters. Mask-like faces is what we use the term, that is expressionless faces. The deep tendon reflexes, they are unaltered. The plantar reflex, it is the flexor response. The plantar reflexes, the flexor response. Now, the question that I will ask you now is, what is the earliest clinical feature in patients with the Parkinsonism? Earliest clinical feature that you have in patients with the Parkinsonism. Anyone? Very good, Kranti Reddy. So it is constipation, right? That will be constipation. And then followed by that, these patients will also have anosmia. Okay, so constipation or anosmia, this will be the earliest clinical feature that you will have in patients with the Parkinsonism, not tremors. Parvez, it is not tremors. But if the question is asked, what is the earliest motor manifestation? Then what will be the answer? What will be the earliest motor manifestation in patients with Parkinsonism? Right. So here the answer will be tremors. Right here the answer will be tremors. Okay. Right. Then yes. So this is the biopsy picture in patients with the Parkinsonism. Can anyone identify what is this particular body? This is a biopsy picture in patients with Parkinsonism. Can anyone identify what is that? Right. Very good, Kranti Reddy. So this is your Lewy body, right? And what is the protein that you will have in the Lewy body? The protein that you have in patients with the Lewy body of your Parkinsonism is the alpha-synuclein protein. Okay, so it is it is not tau protein. Tau protein, you get that in case of Pick's disease. Here, it is your alpha-synuclein protein that will be present. All right, so this is about your story related to the Parkinsonism. Okay, right. Then, yeah, so this is the cut section where you will observe that substantia nigra, there is loss of pigmented nerve cells. Okay, you see, there is loss of pigmentation. Right, there is loss of the pigmentation here, whereas here the pigmentation is present, which is the normal substantia nigra. Right. Okay, you see this clinical question. A 50-year-old male presented with complaints of ptosis, difficulty in chewing, and occasional difficulty in swallowing. Right. There is no history of diplopia or visual loss. On examination, there is asymmetrical ptosis, mild restriction of extraocular muscle movement with finger abduction test up to 60 degrees. Nerve conduction study shows decremental response in orbicularis only. Right. Decremental response in orbicularis only. Electroretinogram revealed myopathic pattern. Antibody anti-acetylcholine receptor radioimmunoassay was negative. What is the most probable diagnosis? Right. So it is not the ocular myasthenia gravis. This is a case of the generalized myasthenia gravis. This is a case of the generalized myasthenia gravis. It is not ocular. Okay. Now, in case of ocular myasthenia gravis, you should have only ocular manifestations. Right, you will have ocular manifestations. Okay, right. Yes, we have a username by Fusion. I'll answer you. The antibodies are negative. Let me tell you about that. So, but in these patients, along with ptosis, there is also difficulty in chewing, which is a feature of generalized myasthenia gravis. There is also difficulty in swallowing. That is also a feature of your generalized myasthenia gravis, right? And in generalized myasthenia gravis, can anyone tell me what is the investigation of choice? Yes. What is the investigation of choice in patients with generalized myasthenia gravis? Anyone? In generalized myasthenia gravis, the investigation of choice is, it is not nerve conduction velocity studies. Very good, Kranti Reddy. So it is single fiber electromyography. Right? It is a single fiber electromyography that is considered as the investigation of choice. Understood? Then you take the antibodies. In this patient, if you observe, the anti-acetylcholine receptor antibodies are negative. Right? Now, the antibodies are positive. The sensitivity of antibodies is only 85%. That means in almost 15% of patients, the antibodies are negative. In 15% of patients, the antibodies are negative. You don't have the antibodies in 15% of patients. Okay. And in case of generalized myasthenia gravis also. Now tell me, what is the investigation of choice in case of the ocular myasthenia gravis? Right? Investigation of choice in ocular myasthenia gravis. Anyone? Yes. No. It is not hydrophonium test. No. It is not ice pack test. Not nerve conduction velocity. It is antibodies again. What is that antibody? No. It is not tensilon test also. It is not tensilon. It is not hydrophonium test. No. What is the antibody in ocular myasthenia gravis? Very good, Chiranjeev and as well as Yadav and Multani. That is anti-musk antibodies. Right? The antibodies that you will have is anti-musk antibodies in patients with ocular myasthenia gravis. That is the investigation of choice. Now, in case of ocular myasthenia gravis, what is the drug of choice? What is the drug of choice in case of the ocular myasthenia gravis? Anyone? So the drug of choice in case of the ocular myasthenia gravis will be prednisolone. Right? So prednisolone is a drug of choice, not pyridostigmine. It is the prednisolone for ocular myasthenia gravis. Whereas you take in case of the generalized myasthenia gravis, in mild form of generalized myasthenia gravis, we give pyridostigmine as the drug of choice. Right? Whereas in moderate to severe form of myasthenia gravis, we give steroids. Right? We give steroids. Okay? Right. So now next important is, what is the earliest clinical manifestation in generalized myasthenia gravis? What is the earliest clinical manifestation in patients with the generalized myasthenia gravis? Yes. Right. The earliest clinical feature will be your ptosis. Very good. That will be ptosis. And that too, a unilateral ptosis will be there. And that too, unilateral ptosis will be there. Understood? So this is about your, and in case of your myasthenia gravis, it is your involvement of the LPS, levator palpebrae superioris muscle. And you also have the involvement of the jaw muscles. You also have the involvement of the facial muscles. And you also ultimately, okay, what is the cause of death in patients with the myasthenia gravis? Anyone? What is the cause of death in patients with the myasthenia gravis? Any one of you? Right. So it is your respiratory paralysis which will be the cause for death in patients with the myasthenia gravis. And the respiratory paralysis will cause the type 2 respiratory failure. That will cause type 2 respiratory failure, where these patients will have the hypoxia and as well as the hypercapnia. These patients will have hypoxia and as well as the hypercapnia. Okay, so this is about your the generalized myasthenia gravis story, right? And ocular myasthenia gravis already we have discussed. Now tell me, is it a presynaptic nerve terminal disorder or is it a postsynaptic nerve terminal disorder? Anyone? Is it presynaptic nerve terminal disorder or is it a postsynaptic nerve terminal disorder? Right. So your generalized myasthenia gravis, it is a postsynaptic nerve terminal disorder. Right. Now, what is that particular disorder, which is also a neuromuscular junction disorder, which is the presynaptic nerve terminal disorder? Yes. What is the disorder where you have a presynaptic nerve terminal disorder? Very good. That will be your Lambert-Eaton myasthenic syndrome, where the antibodies here are formed against the voltage-gated calcium channels. The antibodies are formed against voltage-gated calcium channels. And in Lambert-Eaton myasthenic syndrome, what is the investigation of choice? What is the investigation of choice in Lambert-Eaton myasthenic syndrome? Right? Yes, very good, Chiranji. It will be repetitive nerve stimulation test, where you have incremental response on repetitive nerve stimulation test. And finally, what is the drug of choice in patients with Lambert-Eaton myasthenic syndrome? What is the drug of choice? Drug of choice in case of Lambert-Eaton myasthenic syndrome will be 3,4-diaminopyrimidine. 3,4-diaminopyrimidine. That will be the drug of choice. Okay. Now, what is the tumor which is associated with Lambert-Eaton myasthenic syndrome? Whereas your generalized myasthenia gravis, it is associated with the thymomas, okay, or thymic hyperplasia. But yes, very good, Chiranji. So this Lambert-Eaton myasthenic syndrome, it is associated with the oat cell cancer or oat cell carcinoma, which is nothing but your small cell carcinoma. Which is nothing but your small cell carcinoma. Okay, so this completes the discussion of your myasthenia gravis. All right. Okay, so I have been just talking since almost like 2.5 hours. So I will just take a break. Okay, so you just take a break for 15 minutes, or okay, 15 to 20 minutes. You just take a break, right? And then we will reassemble back and discuss the remaining parts of the medicine today. So I'll be discussing the remaining part of the neurology, and as well as I'll be discussing the remaining part, I mean, the cardiology as well, and gastroenterology. Okay, right. Just take a break. All right. So welcome back. Yes. So am I audible and visible to all of you? Right. Now continuing with the neurology. So you see the next question. That is, a ventrolateral cordotomy is performed to produce the relief of pain from the right leg. It is effective because it interrupts the left dorsal column, left lateral spinothalamic tract, right lateral spinothalamic tract, right corticospinal tract. Any one of you? Right, very good, Chiranjeev. So it is your left lateral spinothalamic tract. So what exactly is this? Like it is a form of a Brown-Sequard syndrome. Now, in case of the Brown-Sequard syndrome, which is the disorder related to the spinal cord, where the individual will have the hemisection of the spinal cord. Where the individual will have the hemisection of the spinal cord. Okay. Now, in case of your Brown-Sequard syndrome, you need to know what will be the clinical features at the site of lesion and what will be the clinical features below the site of lesion. At the site of lesion, what will be the motor manifestations and sensory? Below the site of lesion, what will be the motor manifestations and as well as the sensory? Now, you take at the site of lesion. At the site of lesion in case of Brown-Sequard syndrome, the sensory changes will be like ipsilateral dermatomal pattern, sensory loss will be there. And motor changes will be in the form of damage to your anterior horn cell, where the patient will have the element feature at the site of lesion. Whereas below the site of lesion, the motor manifestation will be in the form of the UMN lesion, right? So the motor manifestations will be in the form of the UMN signs. Okay. Whereas the sensory changes, if you observe below the site of lesion, ipsilateral dorsal column sensations will be lost because dorsal columns, they don't cross at the level of the spinal cord, they cross at the level of the brainstem. And contralateral loss of your spinothalamic tract sensation. Why contralateral spinothalamic tract sensation are being lost? Because the spinothalamic tract, they cross at the level of the spinal cord. So at the below the level of lesion, you have the spinothalamic tract on the right side of the left side. Okay, on the right side of your spinal cord, you have the spinothalamic tract of the left side. So below the site of lesion, you have ipsilateral dorsal column sensations being lost, contralateral spinothalamic tract sensations which are being lost. Okay, so that is what is your Brown-Sequard syndrome. So in order to have the relief of pain from the right leg, spinothalamic tract sensations are the one which will carry your pain and as well as temperature and crude touch sensation. It is effective because it interrupts the left lateral spinothalamic tract sensations. Okay, right. So that is about your Brown-Sequard syndrome, which is the hemisection of the spinal cord. Right. Now, we will move on to the next topic. And what is the treatment in these patients with your Brown-Sequard syndrome? First and foremost, whenever there is hemisection or injury to half of the spinal cord, you need to advise the individual for immobilization. Now, apart from immobilization, can anyone tell me what is the drug that will be effective in the treatment? Yes. What is the drug which can be effective in the treatment when you give in early stages? Early treatment should be with any one of you. The early treatment, you should give high dose steroids, right? You should give high dose steroids. Okay. So this particular high dose steroids, they may improve the neurological recovery. Okay. But it should be given the high dose steroids, like example, which one we give is methylprednisolone we give. Methylprednisolone should be given at a dosage of 30 milligrams per kg body weight by intravenous route bolus. And that should be given within 8 hours of the spinal cord injury. Then the recovery will be good. Then the recovery will be good. Okay, right. Next question. The child presents with ascending flaccid paralysis. There is subsequent respiratory muscle involvement also. CSF examination showed albuminocytological dissociation. What is the treatment of choice in this patient? So first of all, can anyone tell me what is the diagnosis of this clinical scenario? Yes. Yeah, very good, Pranav Mohanan. It is the Guillain-Barré syndrome. So in patients with Guillain-Barré syndrome, you have acute flaccid paralysis. Acute ascending flaccid paralysis will be there in patients with the Guillain-Barré syndrome. And in patients with the Guillain-Barré syndrome, the drug of choice will be your intravenous immunoglobulins. So can anyone tell me what is the alternative treatment for the Guillain-Barré syndrome? Apart from your intravenous immunoglobulin. Very good, Pranav Mohanan. So that is the alternative treatment will be in the form of the plasmapheresis that you need to do. Plasmapheresis is the alternative form of treatment. Now you take this Guillain-Barré syndrome. We have totally 4 forms. What are these 4 forms of the Guillain-Barré syndrome is? These 4 forms include AIDP, that is acute inflammatory demyelinating polyneuropathy. Second one is your AMAN, that is acute motor axonal neuropathy, right? And then followed by that, ASMAN, acute sensory motor axonal neuropathy. Then MFS, which is the rarest form is your MFS, that is Miller-Fisher syndrome. Now, the quick question here is, what is the most common cranial nerve which is affected in patients with Guillain-Barré syndrome? Yes, what is the most common cranial nerve affected in patients with the Guillain-Barré syndrome? Excellent. That is, seventh nerve involvement will be there. But if you see the question of the Miller-Fisher syndrome, what is the most common cranial nerve affected in case of the Miller-Fisher syndrome? Anyone? Right, very good. So the cranial nerve which is affected in case of the Miller-Fisher syndrome will be your third nerve. That is very, very important, right? Then in case of and among these 4 forms, which is the most common form of Guillain-Barré syndrome? It is your AIDP, that is acute inflammatory demyelinating polyneuropathy. That is the most common form of your Guillain-Barré syndrome. Now tell me, Guillain-Barré syndrome is which type of hypersensitivity reaction? What type of hypersensitivity reaction is your Guillain-Barré syndrome? Anyone? So that will be your type 4 hypersensitivity reaction. It's a delayed hypersensitivity reaction, right? And it is not type 2. It is not type 2. It is your type 4. Okay, right. And what is the most common organism? Right? What is the most common organism that will induce the demyelination by antibody formation? Anyone? Yes, very good. That is Campylobacter jejuni. Campylobacter jejuni. Now, it's an autoimmune disorder, right? Can anyone tell me what is the name of these antibodies? What is the name of the antibodies in patients with the Guillain-Barré syndrome, which will be causing the demyelination? Yes. So many ads are coming, right? Yeah. So very good. So that is your anti-GQ1 antibodies. Anti-GQ1 antibodies, right? Now, yes, Anik and as well as Dabade, you are telling like anti-GM1 antibodies, right? So your anti-GM1 antibodies and as well as the anti-GQ1 antibodies, they are the one which are responsible for your Guillain-Barré syndrome. And even in case of Miller-Fisher syndrome, you have this specific antibodies, all right? Then now, what will be the CSF examination in patients with the Guillain-Barré syndrome? What will be the CSF examination in patients with the Guillain-Barré syndrome? Yes. The CSF examination in patients with the Guillain-Barré syndrome will be albuminocytological dissociation. Right? Albuminocytological dissociation. That is what you will observe in the CSF of patients with the Guillain-Barré syndrome. And what is the drug of choice? Already we have discussed, that is the intravenous immunoglobulin. The alternative will be the plasmapheresis. Now tell me, is there any role of steroids in patients with Guillain-Barré syndrome? Is there any role of steroids in patients with the Guillain-Barré syndrome? Right? So there is no role of steroids in patients with Guillain-Barré syndrome because it is not the new antibody formation. Already the antibodies have been formed and they are causing the demyelination. And one more important point is the prognosis. How is the prognosis in patients with the Guillain-Barré syndrome? Right? The prognosis is the good prognosis. Okay. So almost like 90 to 95% of individuals, they will have the complete recovery. But if at all, if there is death, what is the cause of death in these patients? If at all, if there is death, what is the cause of death in patients with the Guillain-Barré syndrome? Anyone? What is the cause of death in patients with the Guillain-Barré syndrome? Right. So the cause of death in patients with the Guillain-Barré syndrome will be respiratory paralysis. Right. And that too, the type of respiratory failure that these individuals will develop is your type 2 respiratory failure. Okay. So this is about your story related to the Guillain-Barré syndrome. Right. Next. A 66-year-old woman complains of stiffness and weakness climbing the stairs. And she has history of hypertension and diet controlled type 2 diabetes mellitus. On examination, there is mild upper arm weakness. His hip flexion is 4 minus by 5 bilaterally, with bilateral wasting and flickering of the fasciculations in the right quadriceps. Knee extension is like 4 by 5. Brisk knee and ankle jerks are elicited, as well as a positive Hoffman's and Babinski sign is present. Sensory examination, cranial nerves are absolutely normal, right? And pulse is regular, blood pressure 178 by 97. What is the most likely diagnosis? Very good. So the answer in this question is the amyotrophic lateral sclerosis. Okay. Yes. Pranav Mohanan, please tell me why you have the answer it as your amyotrophic lateral sclerosis. Right. Very good, Sham. So this patient has both the upper motor neuron and as well as the lower motor neuron manifestations. Okay. Now, what are the upper motor neuron manifestation? The upper motor neuron manifestations, they are your brisk reflexes. The reflexes are brisk. And yeah, so you have brisk knee and as well as the ankle reflex, right, which is a feature of upper motor neuron lesion. Then Babinski sign is positive, which is also the feature of the upper motor neuron lesion. Now, what are the features of lower motor neuron lesion? What are the features of lower motor neuron lesion? The features of lower motor neuron lesion will be the presence of the fasciculations. Presence of the fasciculations will be your lower motor neuron features. Okay. So because the patient is having both UMN and as well as LMN, that is suggestive of your amyotrophic lateral sclerosis. Now, you take in case of spinomuscular atrophy. In spinomuscular atrophy, what form of motor neuron disease is your spinomuscular atrophy? Yes. Which form of your motor neuron disease is your spinomuscular atrophy? Very good. So it is the LMN paralysis. It is only LMN lesion. Whereas in primary lateral sclerosis, what is that you will observe? In primary lateral sclerosis, what is that you will observe? Anyone? Oh, where is the chart? Yeah. Right. In case of the primary lateral sclerosis, it is predominantly UMN lesion, that is upper motor neuron only. Right. Now, you take this motor neuron disease, the motor neuron disease, this is mainly due to impaired neuronal viability. So can anyone tell me that impaired neuronal viability is due to mutation of which particular gene? Impaired neuronal viability is due to mutation of which particular gene? It is superoxide dismutase 1 gene. Right, superoxide dismutase 1 gene. And at the same time, you also need to know the type of mutation. Right? Can anyone tell me what is the type of mutation? What type of mutation is your superoxide dismutase in case of your motor neuron disease? Right? So it is a hexanucleotide repeat. Right, it is the hexanucleotide repeat. And because of this mutation, there will be increase in the excitatory neurotransmitter, and that excitatory neurotransmitter is the glutamate. Okay, so this glutamate which is increased, that is the one which will cause the free radical damage of the neurons. Right, that is the one that will cause the free radical damage of the neurons. Okay, and in patients with your motor neuron disease, there is no bladder and bowel involvement. right? There is no bladder and bowel involvement in case of the motor neuron disease. And in patients with motor neuron disease, there is no sensory involvement also. Sensory manifestations, you don't have sensory manifestations are not present in patients with the motor neuron disease. And in patients with motor neuron disease, even your higher mental functions, right? Even your higher mental functions will be absolutely normal, and ocular motility is spared. Right, ocular motility will be spared. Okay, and what will be the most common symptom in patients with your motor neuron diseases? Fasciculations is the most common symptom. And what is the most common cause of death in patients with motor neuron disease? What is the most common cause of death in patients with motor neuron disease? That is again respiratory failure, and that too your type 2 respiratory failure. That is what you will observe. Okay, now you need to know the treatment. See, we don't have any particular drugs which can completely reverse the disease. Only thing like we can do is we can only stop the progression, we can prevent the progression. So what are the drugs which will prevent the progression? Yes, the drugs which can prevent the progression in case of amyotrophic lateral sclerosis are, anyone? So we have two important drugs. One is your idavarone, right? And the another important drug is the riluzole, right? The another important drug is riluzole. So these are the two drugs which can prevent the progression of this particular disease. But the treatment for spinomuscular atrophy is very much expensive because it is a therapy which is related to the gene. Yeah, can anyone tell me what is the treatment of the spinomuscular atrophy? What is the drug that we give for spinomuscular atrophy? Anyone? The drug that we give for spinal muscular atrophy is nusinersen. Right, nusinersen. So this nusinersen, okay, this nusinersen, it is an antisense oligonucleotide. It is an antisense oligonucleotide. Okay, so in case of spinomuscular atrophy, it is actually the protein that is being defective is spinomuscular nuclear protein, and that is sensed. I mean, that is encoded by the gene called SMN2 gene. Okay, it is coded by this gene called the SMN2 gene. Now, what this nusinersen will do? Nusinersen, it is the one which will increase the efficacy of your SMN2 gene, and that is the reason why in spinal muscular atrophy we give nusinersen. All right. Then, in case of spinal muscular atrophy, the another important form of gene therapy is your nusinersen was SMN2, right? And we also have the SMN1 as well, right? And what is this particular SMN1 and how is this SMN1 introduced? The SMN1, it is introduced by a viral vector. What is the viral vector which is used for the injection of this SMN1? Okay, that particular viral vector, it is, yeah, you can just make out this pronunciation. That is onasemnogene abiparvovec. That is the gene therapy for your SMA. That is actually the viral vector which is used for the delivery of your SMN1. Okay, so that is about your motor neuron disease. So the treatment for spinal muscular atrophy is very, very expensive. These particular gene therapy, it costs crores for the patient. Okay, right. Now, next topic. So that was about your motor neuron disease. Then you take the next topic in the neurology. 30-year-old female presents with complaints of gradual onset weakness of legs for 1 month with reduction in the visual acuity and urinary incontinence for past few days. The contrast MRI shows periventricular lesion. Which of the following drug is not used in these patients? Yes, Multani, you have to remember even for FMG exam also, right? So the efficacy, I mean, the toughness of your FMG paper is almost equivalent to your NEET PG paper in the recent times. As such, there is no difference in the quality of the paper between FMG and as well as NEET PG at all. Yeah. Yes, very good, Mandar. So metotane, okay, first of all, can anyone tell me what is the diagnosis? Yes, what is the diagnosis in this clinical scenario? The diagnosis in this clinical scenario is like multiple sclerosis. Now, Can anyone tell me what are these particular lesions which are shown in the MRI? What are these lesions which are shown in the MRI in the periventricular area? Yes, what are these lesions? Right. These lesions, they are considered as, yes, very good, Multani. So they are called Dawson's fingers. Okay. So they are nothing but your fibrotic plaques which are distributed in the periventricular area. Fibrotic plaques in the periventricular area, which are called as the Dawson's fingers. Okay. Now, in case of multiple sclerosis, in acute cases, right, acute cases of multiple sclerosis, please tell me what is the drug of choice for acute cases? In acute cases, like what is the drug of choice? In acute cases of your multiple sclerosis, the drug of choice will be methylprednisolone, right? And the other drugs, your fingolimod, beta interferon, glatiramer acetate, they are given as disease modifying therapy, DMT. DMT stands for disease modifying therapy. Okay, we have many other drugs like we have glatiramer acetate, natalizumab, fingolimod, mitoxantrone, dimethyl fumarate. Then we have teriflunomide, alemtuzumab. These are all the drugs which are given as disease modifying therapy. Okay, but tell me in which clinical condition we use mitotane? Yes, in which clinical condition we give mitotane? Anyone? So we use this mitotane. No, not in pheochromocytoma. We use this mitotane in patients with the Cushing syndrome. In patients with Cushing's, we give this mitotane. Understood? Right. So that is about the treatment of the multiple sclerosis. Yes. Which of the following is the investigation of choice for the diagnosis of the multiple sclerosis? Right. So that will be your MRI. So what does this MRI shows? The MRI shows the presence of the plaques. Right, that is the periventricular plaques will be there, and this periventricular plaques, they are being described as the Dawson's fingers. Right, they are being described as the Dawson's fingers. Okay, right, that is what the MRI shows. And the next important is the lumbar puncture. Can anyone tell me what does the lumbar puncture shows in patients with multiple sclerosis? Yes, that is your CSF electrophoresis in patients with multiple sclerosis will show you the presence of the oligoclonal bands, right? And what does this oligoclonal bands contain? This oligoclonal bands, it contains the presence of the IgG antibodies, right? The presence of IgG antibodies. And the next important is the visual evoked potentials. Right, the next important is the VEP, that is visual evoked potentials. Now, can anyone tell me what does this visual evoked potentials will show you? What does this visual evoked potentials will show you? The visual evoked potentials will show you that there is reduced amplitude of that there is reduced amplitude of voltage across the optic nerve. Right, across the optic nerve, you will notice that there is reduced amplitude of the voltage across the optic nerve. Okay, right, yeah, the latency period is increased. So these three together, they are placed in which criteria? Right, the name of the criteria is the McDonald's criteria. The name of the criteria will be McDonald's criteria. Right, next, now the very important is like what is the most common symptomatology in patients with the multiple sclerosis? Yeah, multiple sclerosis is associated with all of the following except. Multiple sclerosis is associated with all of the following except. Mandar, except is the question asked. So the one that you don't see in case of the multiple sclerosis is, yes, very good. So hydrocephalus is not the feature of your multiple sclerosis, right? But if the question is asked, what is the most common symptomatology in patients with multiple sclerosis? What would be the answer? What is the most common symptomatology in patients with the multiple sclerosis? What will be the answer? Yeah, so it is like your fatigability and as well as the sensory symptoms. Actually, sensory symptoms, they are the most common manifestation. It is not optic neuritis sham. It is the sensory symptoms. And this sensory symptoms will be in the form of paresthesia, dysesthesia, then hyperesthesia. That will be your sensory symptoms. And followed by the sensory symptoms, you have the involvement of the optic nerve. That is optic neuritis will be there, right? So optic neuritis, it is typical. Okay, it is mostly unilateral, but occasionally there can be bilateral optic neuritis as well. And because of this optic neuritis, these patients, they will present with diplopia and as well as the blurring of the vision. Diplopia and as well as blurring of the vision. Okay. Now, apart from this optic nerve, there will be also demyelination of the corticospinal tract. Because of the demyelination of the corticospinal tract, these patients will have the upper motor neuron sign, spasticity, brisk reflexes, Babinski sign, all these will be there, right? And these patients, they also have the bladder involvement. And the bladder dysfunction is seen in almost 90% of patients. And even bowel involvement will be there. That bowel involvement will be in the form of constipation in these patients. And even certain cranial nerves are affected. Apart from your optic nerve, there can be involvement of the fifth nerve, ninth nerve, 10th nerve. Okay. And there will be also involvement of cerebellum, due to which these patients will have ataxia. These patients will have ataxia. Okay. So right. So these are the manifestations that you will have in patients with the multiple sclerosis. Yeah, very good, Mandar. So you also have the INO, that is internuclear ophthalmoplegia. But Mandar, can you tell me your internuclear ophthalmoplegia is due to demyelination of which structure? Internuclear ophthalmoplegia is due to demyelination of which particular structure? Anyone? So internuclear ophthalmoplegia, it is due to demyelination of the median longitudinal fasciculus, right? Median longitudinal fasciculus. Very good, Mandar. Now, these patients with the multiple sclerosis, they also have Lermite sign. So what is that particular Lermite sign? Lermite sign is that upon flexion of the neck, these patients, they will complain the electric shock-like sensation, right? They complain the electric shock-like sensation down the spinal cord. They complain of electric shock-like sensation down the spinal cord. That is what is called as the Lermite sign. Now, can anyone tell me the differential diagnosis for Lermite sign apart from multiple sclerosis? What are the other conditions where you can have the presence of Lermite sign? Anyone? The other conditions where you can have the presence of Lermite sign is you come across this Lermite sign in patients with cervical spondylosis, right? You come across this Lermite sign in patients with vitamin B12 deficiency, right? And you come across this Lermite sign in cases of the pyridoxine toxicity. Right, in cases of the pyridoxine toxicity. So, and even in cases of cervical myelopathy. So these are all the conditions, right? These are all the conditions where you can have the presence of the Lermite sign, right? Okay, right. So, like these were some of the important topics in the neurology, right? We will take few more topics in the neurology, but before that, let us start with the topics related to the cardiology, right? So let me just do a quick revision of the cardiology. Yes, am I audible and visible to all of you? Because, yeah. Right. So now in the cardiology quick revision, first let me take up the topic of the heart failure. Okay. Any one of you? Like we have a 56-year-old man with the history of the coronary artery disease and a documented ejection fraction of the 40% by echocardiography presents for further management. At this visit, the patient denies having shortness of breath, dyspnea on exertion, orthopnea, or lower extremity edema. He has never been admitted to hospital for congestive heart failure. According to the American Heart Association, which particular stage of the heart failure is this particular patient comes under? Yeah, yes, Augie, the cockroaches. Maybe another 1 hour. Another 1 hour, I will do the session. Okay. Right. So, which particular stage does this particular patient comes under? No, it is not stage A. It is not stage A. Telegram quiz will be there as usual. That will be conducted. It is automated. And the Telegram quiz will be there at 10 o'clock. Right. Very good, Subhan Parvez. So that is your stage B. That will be your stage B. Now, what is this? Right. What is this stages of your heart failure is? So now you see, is this particular patient symptomatic? No. The individual is like denying the symptoms. The individual is asymptomatic. But this particular patient is having the ejection fraction less than 40%. That means there is some cardiac pathology. Coronary artery disease is also there. So you take the stages of the heart failure. So if you take the stages of heart failure, in stage A, the patient is at risk of heart failure, but there is no structural disease. What would be the risk factors? The risk factors would be like diabetes and as well as the hypertension. Whereas in stage B, the individual is having the risk factors, but there is no heart failure symptoms, but structural disease is being present. This is actually the clinical scenario of our patient. Whereas stage C, these patients, they have structural disease along with that heart failure symptoms will be there. And stage D is like advanced stages of your heart failure. It's like refractory heart failure. Okay. And in cases of your stage D, advanced heart failure or refractory heart failure, these patients, they require the heart transplantation. These patients, they require heart transplantation. So this is about your heart failure. Now, can anyone tell me what is the most common? You take like heart failure, like you have right and as well as the left heart failure. What would be the most common cause of right heart failure? What would be the most common cause of right heart failure? Yes. Yeah, the most common cause of the right heart failure will be left heart failure. Yes, Multani. But sir, ejection fraction is low. Why stage B? Actually, why the ejection fraction is low? That is because of your coronary artery disease, right? So when there is a coronary artery disease, the ejection fraction is less. That means it's a structural pathology, right? How much is the normal ejection fraction? That is 55 to 70%. But here the ejection fraction is reduced. That means there is structural pathology of the heart. Okay, so that's the reason why the individual comes under your stage B. But the point is the individual is asymptomatic. That is the reason why it is your stage B, but not stage 3, right? Or stage C. Okay, right. And right. Now, what is the most common cause of the acute cor pulmonale? Most common cause of the acute cor pulmonale. Yes. The most common cause of the acute cor pulmonale, that will be massive pulmonary embolism. No, it is not COPD. COPD is the most common cause for chronic cor pulmonale. Most common cause for chronic cor pulmonale, then the answer will be your COPD, right? And how do we classify the heart failure in the recent times? The heart failure is being classified based on the ejection fraction, right? Where the individual will have heart failure with reduced ejection fraction, the ejection fraction will be less than 40%, and heart failure with preserved ejection fraction, where the ejection fraction will be more than 50%. And your heart failure with reduced ejection fraction will be your systolic heart failure, right? And heart failure with preserved ejection fraction will be your diastolic heart failure. Okay. Now, my quick questions are dilated cardiomyopathy. What type of heart failure is there? Dilated cardiomyopathy. What type of heart failure is that? Anyone? So is it like reduced or preserved ejection fraction? So if you take dilated cardiomyopathy, very good, Kailash Khatri. So it is heart failure with reduced ejection fraction. Whereas, what is the condition where, which type of cardiomyopathies you have preserved ejection fraction is restrictive cardiomyopathy and as well as hypertrophic cardiomyopathy, you have the preserved ejection fraction. All right. Now, the next question is, what is the earliest clinical feature of the left heart failure? Yes, what is the earliest clinical feature of the left heart failure? Any one of you? Earliest clinical feature of the left heart failure? No, you should tell me like which form of dyspnea. Dyspnea is not the answer. It should be like PND. Paroxysmal nocturnal dyspnea is what you should answer it as. Paroxysmal nocturnal dyspnea is the earliest clinical manifestation of left heart failure. And as the severity of the left heart failure increases, then these patients will have the dyspnea at rest, dyspnea on exertion, and orthopnea. So this NYHA classification is very, very important. That is New York Heart Association classification. In class 1, the individual is not symptomatic. Ordinary physical activity does not cause any symptoms. It is only exertional activity which will produce symptoms in class 1. Whereas class 2, there is slight limitation of the physical activity, right? And these patients, they are comfortable at rest, and ordinary physical activity will cause the symptoms in case of your class 2. And in class 3, there is marked limitation, right? So marked limitation in the sense, these patients will have the dyspnea when they do less than ordinary activity also. And class 4 is that where the individual is unable to carry out any physical activity. Class 4 is that where the individual is unable to carry out any physical activity without discomfort. So these patients, they have dyspnea at rest. These patients, they have the dyspnea at rest. Okay. Now, this was about your left heart failure. But tell me, in right heart failure, what will be the earliest manifestation? In right heart failure, what will be the earliest manifestation? Yes. In right heart failure, the earliest manifestation, it is not pedal edema, right? It is your raised JVP. The hepatojugular reflex will be positive and JVP will be elevated. That is the earliest manifestation in patients with your right heart failure. Now, can anyone tell me what is the name of the criteria for your heart failure? What is the name of the criteria for the heart failure? Yes, the name of the criteria for your congestive heart failure, very good, Mandar. So that will be your Framingham's criteria. That is your Framingham's criteria, right? Next important is you take the workup in patients with your heart failure. What is the most sensitive cardiac biomarker? What is the most sensitive cardiac biomarker in patients with your congestive heart failure? Right. It is not just BNP, Mandar. You should answer it as NT-proBNP. You should answer it as the NT-proBNP. Kailash Khatri, troponin is your cardiac biomarker for coronary artery disease, not for your heart failure. Okay. So the most sensitive cardiac biomarker for heart failure will be your NT-proBNP. All right. Then what are the other cardiac biomarkers that will be positive in patients with a congestive heart failure apart from NT-proBNP? Apart from NT-proBNP, the other cardiac biomarkers are atrial natriuretic peptide, adrenomedulin, and then endothelin. These are the other cardiac biomarkers for the congestive heart failure. Okay. Now, what is the drug of choice for acute left ventricular failure? Anyone? What is the drug of choice for acute left ventricular failure? Yes, drug of choice for acute left ventricular failure. Drug of choice for acute left ventricular failure will be furosemide. Very good, Mandar. So furosemide is the drug of choice for acute left ventricular failure. It is not ACE inhibitors multani, it is furosemide, because in acute left ventricular failure, these patients, they have the pulmonary edema. So to reduce the pulmonary edema, we need to give the furosemide, right? And in case of chronic heart failure, what is the drugs that we give is, we give beta blockers, ACE inhibitors, and aldosterone antagonists. Can anyone tell me what is that fourth group of drug which has been recently added? The one which will reduce the mortality. So improving the mortality in the sense like reducing the mortality. Okay. Yeah, your RB is again Ruchika. It is your ARB, right? ARB and neprilysin inhibitor. That is okay. But any other group of drug which has been recently added? Yes, very good, Multani and as well as Ruchika. So this will be your SGLT2 inhibitors. SGLT2 inhibitors, that is your dapagliflozin, canagliflozin, and empagliflozin. These are your SGLT2 inhibitors. Okay, they are the one which will reduce the mortality and which will improve the outcome of the individual. Now, whenever you are giving beta blockers, which are the beta blockers that you will give? Right, the beta blockers that you need to give is BMC, that is your bisoprolol, okay, and then metoprolol, and then carvedilol. Right, so these are the beta blockers. And what is the drug of choice for your heart failure with reduced ejection fraction? Heart failure with reduced ejection fraction, the drug that we give is your ARNI, that is angiotensin receptor blocker, that is valsartan, neprilysin inhibitor, that is sacubitril. Now, what is the advantage of this particular ARNI is the ARNI is the drug which will improve the ejection fraction in patients with the heart failure with reduced ejection fraction. Okay. Now, I'll give you a clinical scenario. Please tell me your treatment. A patient with a heart failure is having the atrial fibrillation. What is the drug that you will give? A patient with heart failure is having the atrial fibrillation. What is the drug that you will give, administer? Yes. The drug that you will administer in this scenario is very good, Multani. So you need to give digoxin. Digoxin, it has the dual activity in this scenario. Digoxin in heart failure, it is a positive inotropic agent, right? And in atrial fibrillation, it will be acting as an AV nodal blocking agent and it will reduce the ventricular rate. So that is the reason why we give digoxin if the patient is having heart failure with atrial fibrillation. So can anyone identify this image? The image shows the presence of, right? The image shows the presence of anyone? It is not ICD, Sham. It is not ICD. If you take, there are three leads in this patient. There is one lead in right atrium, another lead in right ventricle, and another lead in the lateral wall of the left ventricle. It is not ICD. ICD will have only two leads. No, no, no. Mandar, even your dual chamber pacemaker also will have only two leads. Then what is left out now? Right, very good, Praveen. So it is your cardiac resynchronization therapy. It is your cardiac resynchronization therapy. So where do we use this cardiac resynchronization therapy is in patients with the DCMP, dilated cardiomyopathy with wide QRS complex. Right, where the QRS complex of the individual is like more than 120 milliseconds. But initially, we don't place this your CRT. If the individual is refractory to medical management you have given, but still individual is refractory and DCMP patient, wide QRS complex, then you put the patient on CRT, cardiac resynchronization therapy. Now, what is the advantage of your CRT is CRT will improve the ejection fraction in patients with the dilated cardiomyopathy. Okay, so this is about your heart failure story. Now you take this next topic, that is cardiomyopathy. So in case of cardiomyopathy, you need to be very much aware of what is the most common form of the cardiomyopathy. Anyone? What is the most common form of the cardiomyopathy? Yeah, Kajal, when do we use this dual pacing is, we use this dual pacing in patients with complete heart block. In patients with complete heart block, we use this dual pacing, all right? Next, yeah. So the most common form of your cardiomyopathy will be your dilated cardiomyopathy, right? And what is the most common toxin? Most common toxin that will be causing your dilated cardiomyopathy? Most common toxin that will be causing your dilated cardiomyopathy will be your alcohol. Okay, so your toxic cardiomyopathy is the most common form of the cardiomyopathy. Understood? Now, you see this question. A 44-year female, known case of the breast cancer, is on chemotherapy since 2 years. She is HER2 positive, HER2 receptor positive. She presented to the emergency department with history of dyspnea, and she takes the drug subcutaneously for that breast cancer. What is the drug that she is taking? Very good. So in case of your HER2 receptor positive and the drug which is being taken subcutaneously, the drug is your trastuzumab. So what I just wanted to tell you is your chemotherapeutic drugs, that is your adriamycin, trastuzumab, daunorubicin, and cyclophosphamide. All of them, they are responsible for the development of your dilated cardiomyopathy. But the one which are given in case of HER2 receptor positive and as well as your subcutaneous route is your trastuzumab. That is very, very important. Now, does anyone know what are the autoimmune conditions that will be responsible for your dilated cardiomyopathy? Yes. What are the autoimmune conditions that are responsible for the development of dilated cardiomyopathy? Anyone? Which are the autoimmune conditions where you have the development of dilated cardiomyopathy? Anyone, quickly. So the autoimmune conditions where you have the development of dilated cardiomyopathy will be, that is the SLE, systemic lupus erythematosus. You can have the development of your Sham, your DMD is what? DMD is like Duchenne's muscular dystrophy. It is a congenital pathology. It is mainly due to gene mutation. That is, dystrophin gene mutation will be there in case of your DMD. That is not an autoimmune condition. Understood? Now, you should know what are the nutritional deficiencies that will be causing dilated cardiomyopathy. Any one of you? Nutritional deficiencies that will cause dilated cardiomyopathy. Yeah, Multani, I will tell you the endocrine pathologies, but tell me the nutritional deficiencies. Very good, Pranav Mohanan. One is your selenium deficiency and the other one is the thiamine deficiency, right? Now, yes, Multani, what are the endocrine causes for your, right? What are the endocrine causes for dilated cardiomyopathy? Endocrine causes for dilated cardiomyopathy. So the endocrine causes associated with your dilated cardiomyopathy will be, right, very good, Multani. It is your thyroid disorders. It is not only hypothyroidism, Multani. It is both hypo and as well as hyperthyroidism. Along with that, even diabetes mellitus is also associated with the dilated cardiomyopathy. Does anyone can guess what is the hematological cause for dilated cardiomyopathy? Hematological cause for dilated cardiomyopathy. Yes. The hematological cause, the one which for dilated cardiomyopathy will be your sickle cell anemia. That will be your sickle cell anemia. Now, can anyone tell me what is the endocrine disorder associated with your sickle cell anemia? Yes. What is the endocrine disorder associated with sickle cell anemia? Any one of you? So, the endocrine disorder associated with not diabetes mellitus, it is the one nephrogenic diabetes insipidus. Nephrogenic diabetes insipidus is what you observe with sickle cell anemia. All right. Now, tell me what is that infiltrative disorder which will cause both dilated cardiomyopathy and as well as restrictive cardiomyopathy, both. An infiltrative disorder which will cause both DCMP and as well as the RCMP. Very good, Pranav Mohanan. It is your hemochromatosis that will cause both your DCMP and as well as, you are correct, Pranav Mohanan. Why did you delete your message? Right. So, right. It is your hemochromatosis. That is the one which will cause both DCMP and as well as the RCMP. And finally, what are the neuromuscular causes for the development of dilated cardiomyopathy? Neuromuscular causes for the development of dilated cardiomyopathy. Anyone? Neuromuscular causes. So the neuromuscular causes, very good, Mandar, that will be your Duchenne's muscular dystrophy, Friedreich's ataxia, very good, Kailash Khatri, and myotonic dystrophy. Okay, so these three are the neuromuscular causes for your dilated cardiomyopathy. Muscular dystrophy, and that too, which form of muscular dystrophy? That is Duchenne's muscular dystrophy, Friedreich's ataxia, and myotonic dystrophy. Okay, now Friedreich's ataxia, what is the gene that is being mutated? What is the gene mutation in case of the Friedreich's ataxia? Anyone? Yeah, so it is your frataxin gene. So what repeat is it? Is it trinucleotide repeat or hexanucleotide repeat? So this will be the trinucleotide repeat. Okay. And what will be the trinucleotide repeat? That is your poly-GAA. Poly-GAA. All right. Now, and in patients with your dilated cardiomyopathy, whenever you take the chest X-ray, you have the cardiomegaly. Now, what is the criteria for cardiomegaly on the chest X-ray? What is the criteria for cardiomegaly on the chest X-ray? Anyone? So the criteria will be the cardiothoracic ratio will be more than 0.5. That is a criteria for cardiomegaly. Understood? Now, in patients with your dilated cardiomyopathy, what is the first line investigation? It should be more than 0.5. More than 0.5. Okay. Right. The first line investigation in dilated cardiomyopathy will be your 2D echo. And the 2D echo will demonstrate that there is heart failure with reduced ejection fraction, where the ejection fraction will be less than 40%, and they have dilated chambers with functional MR and as well as functional TR. Okay. Now tell me, which of the following drug is not given in patients with your dilated cardiomyopathy? Which of the following drug is not given in patients with dilated cardiomyopathy? Anyone? No, beta blockers we give, Bobby. Kailash Khatri, you have taken classes from me only, cardiology classes. And you also answer beta blockers? Very good. So we have Mandar answering correctly, Parvez answering correctly. That is calcium channel blockers, and even Naveen Rawat. Very good. So we don't give calcium channel blockers. We don't give calcium channel blockers in patients with the dilated cardiomyopathy. See, these patients, they have heart failure with reduced ejection fraction. When you give calcium channel blockers, they further will reduce the contractility. But then why are we giving beta blockers then? Why are we giving beta blockers? We give beta blockers in patients with dilated cardiomyopathy. Why? Anyone? Hmm? So we give beta blockers. The reason is that no, not to decrease the AV conduction or to reduce the heart rate. In patients with your dilated cardiomyopathy, they land up in the heart failure. Whenever they land up in heart failure, there will be increase in the sympathetic activity as a compensatory mechanism. Whenever there is increase in sympathetic activity in patients with your heart failure, that will further worsen the heart failure. And we want to block the sympathetic nervous system. In order to block the sympathetic nervous system, we give your beta blockers. Okay. And even spironolactone and ACE inhibitors, they are also the one which will prevent or which will inhibit your compensatory mechanisms which are activated. So calcium channel blockers should not be given. Okay, but your beta blockers, spironolactone, ACE inhibitors can be comfortably given. Now, this is a very important question. 24-year male patient presented with history of ataxia of gait with Romberg sign being positive and dysmetria present. He also complains of dyspnea on exertion. Echo showed the ejection fraction of 30% with dilated chambers. What would be the etiology? What would be the etiology? Very good, Ruchika. The answer is the Friedreich's ataxia. So the individual is having the ejection fraction 30% with dilated chambers. What will be this suggestive of? This is suggestive of your dilated cardiomyopathy. And there is ataxia and Romberg sign positive with dysmetria, right? Your Friedreich's ataxia, it is spinocerebellar ataxia. It is spinocerebellar ataxia. That means these patients will also have the cerebellar manifestations as well. Understood? So the answer is the Friedreich's ataxia in this case. Right. Indication for this device in DCMP with LBBV patients. First of all, you should identify the device. Right? अरे कितना ads आ रहे हैं? Yeah. Indication of this device in DCMP with LBBV patients. Anyone? First of all, what identify this device? So you have a lead in the right atrium, you have a lead in the right ventricle, and it is not pacemaker. It is not pacemaker, Ruchika, Chavan, and three leads are there. This is another lead. Third lead is there. So if three leads are there, what is it suggestive of? Just now we have discussed, na? It is not ICD Multani. This is your CRT, cardiac resynchronization therapy, right? And what did we discuss about the CRT? Like DCMP along with wide QRS complex. How much should be that wide QRS complex? That should be more than 120 milliseconds. But if you go with your option D, like Mandar, you have gone for option D, then option D is the wrong statement. Option D is a wrong statement. ठीक है? क्यों? Because ये patient को LBB भी है, left bundle branch block is there. So in left bundle branch block, very good, Jaidev Das. No, not Jaidev Das. Parvez, you are right. Okay. So when there is left bundle branch block, already the QRS complex will be wide in LBBB, right? And in order to install or incorporate your cardiac resynchronization therapy in LBBB patients, your QRS complex should be more than 150 milliseconds. Okay. So if LBBB is not there, then it is more than 120 milliseconds. If LBBB is there, then it should be more than 150 milliseconds in a patient with dilated cardiomyopathy refractory to medical management. Understood? Okay. So that was about the story of the indication of your CRT, that is cardiac resynchronization therapy. Now, in pregnancy, in the last month of pregnancy or within 6 months of delivery, okay, let us just take an example, right? We have a 28-year female patient who like pregnant. In the last month of her pregnancy, she presented with sudden onset dyspnea to the emergency department. What could be the cause? Right. Yeah. So that is your peripartum cardiomyopathy. So peripartum cardiomyopathy, this is also a form of your dilated cardiomyopathy. This is also a form of dilated cardiomyopathy, where these individuals will present with dilated cardiomyopathy during the last month of the pregnancy or within 6 months of the delivery. And very important is the female should not be having any pre-existing cardiac disorder. Okay, so absence of demonstrable cause for cardiac failure, right? Absence of a demonstrable cause for the cardiac failure. There should not be any pre-existing cardiac disease. Now, can anyone tell me what are the risk factors for the peripartum cardiomyopathy? Yes, what are the risk factors for peripartum cardiomyopathy? This is very, very important. Risk factors for peripartum cardiomyopathy. So, if you take the risk factors in patients for peripartum cardiomyopathy, very important is preeclampsia, that is pregnancy with hypertension, multiparous females, right, and elderly females. These are the risk factors for peripartum cardiomyopathy. Then finally, you should know how to treat these patients with the peripartum cardiomyopathy. Anyone? How do you treat these patients with the peripartum cardiomyopathy? What is a very, very important drug that you need to supplement in these patients? We need to definitely give beta blockers. There is no doubt in that. And the beta blockers that we give is mainly sotalol. Apart from the beta blockers, what is another important drug? Apart from the beta blockers, what is another important drug? See, the mechanism for the development of your peripartum cardiomyopathy is mainly because of increase in the prolactin. The breakdown products of the prolactin are the one which are responsible for your peripartum cardiomyopathy. Understood? So you need to reduce the prolactin levels. So for which, what is that you need to give? You need to give bromocriptine. You need to give bromocriptine. Okay. So bromocriptine, sotalol, diuretics, these are the mainstay of treatment. Can we give ACE inhibitors in these patients? Actually, in dilated cardiomyopathy, we give ACE inhibitors, right? So can we give ACE inhibitors in this patient? Can we give ACE inhibitors in these patients? ACE inhibitors नहीं देना है क्यों? Because ACE inhibitors, they are teratogenic. ACE inhibitors are teratogenic, so ACE inhibitors should not be given. Understood? Now, followed by that, you see the next question. That is another important form of dilated cardiomyopathy. That is your Takotsubo cardiomyopathy. Anyone? So Takotsubo cardiomyopathy is a type of Takotsubo cardiomyopathy. Very good, Pranav Mohanan. So that is dilated cardiomyopathy. And this Takotsubo cardiomyopathy, you have many names, right? There are totally 4 names for this Takotsubo, right? What are those? One is your Takotsubo. Why is it called Takotsubo? Because the apex of the heart, which is like ballooned out, it is appearing similar to that of a structure which is used in Japan for trapping the octopus. And what is the name of that particular structure? It is Takotsubo. That is the reason why it is called Takotsubo cardiomyopathy. And it is the apex which is ballooned out. That is why it is called apical ballooning syndrome. And it is called stress cardiomyopathy. Why? Because the very important pathogenesis is stress, where there is increased release of catecholamines secondary to stress, and that is what is responsible for your apical ballooning. And this apex of the heart, which is ballooned out, is very thin-walled structure. And whenever there is increase in the pressure within the apex can get ruptured. And that is the reason why it is also called as the broken heart syndrome. And can anyone tell me what is the name of the criteria for your stress cardiomyopathy or your Takotsubo cardiomyopathy? What is the name of the criteria? Anyone? What is the name of the criteria? The name of the criteria is, yes, quickly. The name of the criteria is your modified Mayos criteria. Very good, Kailash Khatri. So it is modified Mayos criteria. So you have four important things in the Mayo, right? Number one, there should be hypokinesia or akinesia of the left ventricle. There should be ST segment elevation and troponin T should be elevated. Hypokinesia, ST segment elevation, troponin T being elevated, they are all actually suggestive of your myocardial infarction. But how will you differentiate that from myocardial infarction is your absence of coronary artery occlusion by a thrombus. In your myocardial infarction, you have the presence of the thrombus in coronary artery. But in Takotsubo cardiomyopathy, you don't have the thrombus in the coronary artery. Then there should be absence of the pheochromocytoma or the myocarditis. Why? Because what is that clinical condition which will differentiate from your Takotsubo is differential diagnosis will be pheochromocytoma, because in Takotsubo also catecholamines are elevated. In pheochromocytoma also the catecholamine levels are elevated. So the close differential diagnosis for your Takotsubo should be your pheochromocytoma. There should be absence of the pheochromocytoma to call it as the Takotsubo cardiomyopathy, right? And how do you treat these patients? The treatment, like we give aspirin, similar to that of your myocardial infarction. We give aspirin, we give beta blockers, we give ACE inhibitors. So we give this aspirin, beta blockers, and ACE inhibitors until the left ventricle fully recovers. We give this your aspirin, beta blockers, and as well as the ACE inhibitors. Now the point is, if these patients develop cardiogenic shock and hypotension, what is the drug that you will give? If these patients develop hypotension and like cardiogenic shock, if there is cardiogenic shock in a patient with Takotsubo cardiomyopathy, what is the treatment that you will give? No, Burani, how can you give beta blockers? Beta blockers will further reduce the blood pressure, right? Yes, Sham. Actually, I was waiting for this type of answers only. Yes, Kailash Khatri. Your Takotsubo cardiomyopathy is already the one which is because of increase in catecholamines. It is your catecholamine toxicity which is causing your Takotsubo cardiomyopathy. So now, Sham and Khatri, can you give catecholamines in this patient? Can you give catecholamines in this patient? Agar if you are giving catecholamines, that will precipitate your Takotsubo cardiomyopathy. You should not give. Catecholamines are completely contraindicated in this patient. So if this particular patient lands up in cardiogenic shock, then you need to place the individual on IABP, that is intra-aortic balloon pump. You need to place the individual on intra-aortic balloon pump. This intra-aortic balloon pump will increase the myocardial perfusion. By increasing the myocardial perfusion, this intra-aortic balloon pump will increase the blood supply to the heart and will increase the cardiac output and will increase the blood pressure. Okay, so that is what is your IABP, intra-aortic balloon pump. So what are the drugs that are completely avoided in patients with your Takotsubo? Dopamine, dobutamine, norepinephrine, they should not be given, right? Whenever you give, the sudden cardiac death can happen within the individual. Okay, so that was about your dilated cardiomyopathy story, right? Okay, all are true regarding the specimen shown except. Yeah, answer. All are true regarding the specimen shown except. Yeah, very good, Ruchika. So what is this specimen suggestive of? This specimen is suggestive of your hypertrophic obstructive cardiomyopathy, right? And in hypertrophic obstructive cardiomyopathy, the ventricle will be banana-shaped left ventricle will be there, right? And they will have diastolic dysfunction only. So initially you will have diastolic dysfunction and later they progress to systolic dysfunction later in patients with the HOCM, hypertrophic obstructive cardiomyopathy. Now, to call it as hypertrophic obstructive cardiomyopathy, what should be increase in the thickness of your left ventricular wall? To call it as hypertrophic obstructive cardiomyopathy, how much should be increase in your thickness of the left ventricular wall? Yes, increase in the thickness of your left ventricular wall, it should be more than 1.5 centimeters to call it as the hypertrophic obstructive cardiomyopathy, right? And this hypertrophy can occur at two places. The hypertrophy can occur at septum. Whenever the hypertrophy occurs at septum, there will be obstruction to the outflow. Once there is an obstruction to the outflow, This we call it as the hypertrophic obstructive cardiomyopathy. And in these patients, the left ventricle will be like banana-shaped left ventricle will be there. Understood? Whereas the hypertrophy can also occur at the apex. The hypertrophy can also occur at the apex, and that we call it as the apical hypertrophy. And in patients with apical hypertrophy, you don't have obstruction, and that is the reason why we just call it as the HCMP, hypertrophic cardiomyopathy, right? And what will be the shape of your LV in your apical hypertrophy? In apical hypertrophy, the shape of the LV will be like ace of spades. Ace of spades. Yeah, this is used for FMGE, this is used for INICT, this is used even for NEET PG. Because for all the 3 exams, the syllabus is same and the standard of exam is also same. Okay. So, right, wherever you are getting the content, please remember that will be useful for NEET PG, FMGE, INICT. Because the standard of the paper is more or less same in all these exams. Right? FMGE doesn't mean that the standard of paper is less. No, even the FMGE standards of the paper is also have been increased a lot. Okay, now what is the gene that is being mutated? What is the gene that is being mutated? Yes? Anyone? Very good, Sham. So it is your beta myosin gene that is being mutated. Okay, and the other mutations will be like myosin binding protein C and as well as the troponin T are being affected. And the type of inheritance is the autosomal dominant type of inheritance, and the beta myosin gene is present on chromosome 14. Present on chromosome 14. And most of these patients are asymptomatic and they present directly with a sudden cardiac death. Right? And what could be the reason for sudden cardiac death in these patients? What could be the reason for sudden cardiac death in these patients? The reason for sudden cardiac death in these patients is the hypertrophied septum or hypertrophied ventricle will induce VT or VF, and that can cause the sudden cardiac death in the individual. And most of them, they are asymptomatic and they directly present with sudden cardiac death. If at all, if they are symptomatic, what will be the most common symptom? What will be the most common symptom if at all if they are symptomatic? Anyone? The most common symptom will be dyspnea in patients with your hypertrophic obstructive cardiomyopathy. Understood? Right. Then in patients with a hypertrophic obstructive cardiomyopathy, you have an additional heart sound. Can anyone tell me what is that additional heart sound that you have in patients with HOCM? Okay. See, all other symptoms can be there. Syncopal attack, chest pain, everything can be there. But the most common symptom will be the dyspnea is the presentation. Right. Very good, Burani. So the additional heart sound that these patients will have is your S4. And that is due to a strong left atrial contraction. Okay. And what is a murmur in these patients with your HOCM, Burani? Yes. What is a murmur in patients with the HOCM? The murmur that you have in patients with your HOCM will be the ejection systolic murmur, or it is also called as the mid-systolic murmur. It is also called as the mid-systolic murmur, right? Very good, Multani. So you have that crescendo-decrescendo pattern, or which we call it as the diamond-shaped murmur, Okay. Now, what is the first-line investigation that you will have in these patients? What is the first line investigation in these patients? Right? Yeah, very good, Mandar. So that is your 2D echo. That will be your first line investigation. That will demonstrate the presence of the hypertrophy. That will demonstrate the presence of the hypertrophy, where the hypertrophy will be there by more than 1.5 centimeters, right? And the ejection fraction will be like heart failure with preserved ejection fraction that you will be observing. And one more important characteristic feature in patients with your HOCM will be presence of SAM. Can anyone tell me what is SAM? Yes, can anyone tell me what is SAM? That is a 2D echo feature in patients with your HOCM. Anyone of you, what is SAM? Yes, Multani, what is SAM? Right? This particular SAM, it stands for systolic anterior motion of anterior mitral leaflet. Okay, you can just observe that here. So during the systole of your left ventricle, the anterior mitral leaflet will move towards the hypertrophied septum, and that is what is called SAM, systolic anterior motion of anterior mitral leaflet, which is peculiar in patients with the HOCM. Right. Now, next is the ECG. Can anyone tell me what is a characteristic ECG finding? What is a characteristic ECG finding? Actually, I have discussed this. Anyone? Okay, you will have the features of left ventricular hypertrophy. Yeah, you will have large Q wave. And Burani, can you tell me what is that the description of that Q wave? What is that Q wave called as? I have said you that name for that Q wave. So that particular Q wave, it is like deep dagger shaped Q waves. Deep dagger shaped Q waves. You have that in V5, V6, and you also have that in 2, 3 AVF leads. Okay, so that is what is your deep dagger shaped Q waves. And finally, okay, answer this question, right? Okay, it's a like a form of repeat question. So a 9-month-old child, a diabetic mother, presents with tachypnea and hepatomegaly. Echocardiography of the heart showed normal morphology with asymmetrical septal hypertrophy. Which of the following will you give to treat this child? Right, that is your propranolol. Okay, so the drug of choice in patients with your HOCM will be your propranolol. Now, what is the alternative drug? Like drug of choice will be your beta blocker. What is your alternative to your propranolol? For example, the individual is having COPD or bronchial asthma. We cannot give propranolol. Then what is the alternative to your propranolol? Anyone? The alternative to your propranolol will be non-dihydropyridine calcium channel blocker, that is diltiazem or verapamil is given. Okay. Now, if suppose if the individual is refractory to medical management, then what is the surgical options that you have? What is the surgical options that you have if the individual is refractory to medical management? The surgical options that you have is ICD we just give only for arrhythmias. Yes, Ruchika and all of you, right? ICD, we place only for arrhythmias. But for obstruction, what will you do? Right? Very good, Mandar. So what you need to do is the surgical ablation. That is your surgical myomectomy should be done. Right? Or surgical myomectomy or alcohol septal ablation should be done. Right? Alcohol septal, where we will inject right, where we will inject 100% alcohol into the septal vessels. Okay, so that is what, and whenever you do surgical myomectomy, the complication that is anticipated is complete heart block. Because whenever you are doing surgical myomectomy, you are like cutting off the interventricular septum. And within the interventricular septum, you have the conducting system. You have that conducting system which is like passing down. So whenever you are like damaging that conducting system, then you need to place the individual on the pacemaker. Dual chamber pacemaker should be placed whenever the individual develops the complete heart block. Okay, so that is a complete. And what are the drugs contraindicated in patients with HOCM is your diuretics are contraindicated, your digoxin is contraindicated, nitrates are contraindicated, and sympathomimetics amines are also contraindicated. Okay, so that is about your story related to the HOCM. Right, now we will move on to the rarest form of your cardiomyopathy, that is your restrictive cardiomyopathy. Right. So can anyone tell me what is the most common cause for the restrictive cardiomyopathy? Yes, what is the most common cause of the restrictive cardiomyopathy? Anyone? So restrictive cardiomyopathy, very good. So the most common cause will be amyloidosis, right? And in restrictive cardiomyopathy, you have increase in the stiffness of the ventricle, and that will result in diastolic dysfunction. That will result in diastolic dysfunction. Okay. And this particular diastolic dysfunction is nothing but the heart failure with preserved ejection fraction. That is what is your restrictive cardiomyopathy. Understood? Now, what are the storage disorders? Right? What is a lysosomal storage disorder that will be causing your restrictive cardiomyopathy? Anyone? A lysosomal storage disorder. Anyone of you? Lysosomal storage disorder. A lysosomal storage disorder, very good, Burani. The answer is Fabry's disease. The answer is Fabry's disease. And in Fabry's, at the same time, you need to be very much aware of the enzymatic deficiency. The enzymatic deficiency is alpha galactosidase A, which is being deficient. And because of that alpha galactosidase A, the fat which is accumulated is globotriosylceramide, and it is a lysosomal storage disorder. Okay. What is a connective tissue disorder that can cause restrictive cardiomyopathy? Connective tissue disorder that can cause restrictive cardiomyopathy. Any one of you? Which is the connective tissue disorder? Excellent. Very good, Burani. That is your scleroderma, right? Scleroderma is the one which can cause restrictive cardiomyopathy. So what is the antibody in this condition causing restrictive cardiomyopathy? Any one of you? Very good. So the answer is not B. The answer is your anti-topoisomerase, because your anti-centromere antibody is present in case of localized scleroderma. That is not associated with your restrictive cardiomyopathy. Whereas anti-topoisomerase is the one which is associated with diffuse form of scleroderma. In diffuse form of scleroderma, the antibody will be your anti-topoisomerase, and that is what is associated with your restrictive cardiomyopathy. Okay, and another connective tissue disorder. Okay, another infiltrative disorder. Very good, Parvez. So even sarcoidosis is also responsible for your restrictive cardiomyopathy. And what will be the clinical symptomatology in patients with your restrictive cardiomyopathy is these patients, they present with palpitations because of the atrial fibrillation, right? And at the same time, you will have the features of your left ventricular failure and as well as the right ventricular failure. And because your atria, like they're abnormally dilated, they have like formation of the thrombus within the right and left atria. That is because of your atrial fibrillation. And because of this, these individuals will also have thromboembolic events. Now, in restrictive cardiomyopathy, very important is the JVP findings. So can anyone tell me what is the important JVP findings in patients with restrictive cardiomyopathy? Anyone? Important. Very good, Ruchika. You have the presence of Kussmaul sign. And apart from Kussmaul sign, Ruchika, can you tell me what are the abnormal waves that you will see in the JVP? Abnormal waves in the JVP. The abnormal waves in the JVP of patients with your restrictive cardiomyopathy is that you have deep X and as well as Y descent. You have the presence of deep X and as well as Y descent. All right. Then you should know what will be the ECG features. So can anyone tell me what will be the ECG finding in patients with restrictive cardiomyopathy? Yes. ECG findings in patients with restrictive cardiomyopathy. Any one of you? Right. They are called as low voltage complexes. Right, low voltage complexes. Okay, so what do you mean by these low voltage complexes? Low voltage complexes is that where the amplitude of your QRS complex will be less than 10 mm in the chest leads, and the amplitude of your QRS complex in the limb leads will be less than 5 mm. So less than 5 mm in the limb leads and less than 10 mm in the chest leads. That is what is called low voltage complexes. And what will be the differential diagnosis for low voltage complexes? Yeah, electrical alternance is different, Mandar. Electrical alternance, you get that in case of cardiac tamponade. Electrical alternance, you see that in case of cardiac tamponade. Okay. Yeah, differential diagnosis will be constrictive pericarditis and as well as the pericardial effusion. Constrictive pericarditis and pericardial effusion, you will have low voltage complexes. Okay. And you take this echocardiogram, you have this speckled pattern. So can anyone tell me where do you have this speckled pattern of the 2D echo in case of the restrictive cardiomyopathy? Speckled pattern means that white dotted appearance is there within the myocardium. So where do you get this? Which etiology of restrictive cardiomyopathy you will have this? right? So you have this in case of very good Multani. That is in case of amyloidosis, you get this particular pattern where you have white dotted appearance, right? And finally, how do you treat? See, the treatment for your restrictive cardiomyopathy is similar to that of the other forms of cardiomyopathy, right? Where we need to give diuretics because these patients ultimately they'll end up in heart failure, right? They'll end up in heart failure. So there will be like pedal edema, there will be pulmonary edema, you need to give diuretics. But the point is, we have discussed that these patients, they are at increased risk of your thromboembolic events. So in order to treat the thromboembolic events, you need to give anticoagulants that is in the form of low molecular weight heparin or oral anticoagulants like your warfarin should be given. And very important drug that should be avoided in patients with your restrictive cardiomyopathy is digoxin. That is very, very important. Digoxin is avoided in patients with restrictive cardiomyopathy because digoxin can precipitate arrhythmias in patients with your RCMP. That is the reason why that should be avoided. Okay, that is about the story related to your cardiomyopathies, right? So, what do you say? Shall we continue or shall we do the remaining part in the next session? Hmm? Okay, so I will just discuss the murmurs, like which is the very important part of the discussion. Yeah, continue. Chalo, chalo. We will do that then. Then some of the basic topics we will take. The basic topics are like pulse. Yeah, like let me discuss the abnormal characters of the pulse. Yeah. Please tell me what are the conditions where you will have the pulsus paradoxus. So pulsus paradoxus is that where systolic blood pressure of the individual falls more than 10 millimeters of mercury during inspiration. That is called pulsus paradoxus. Yeah, very good. So you get this in case of cardiac tamponade. So, okay, I will just discuss the basic topics and wind up. I may not be able to finish the entire cardiology. So I'll take the basic topics. So cardiac tamponade, you have the pulsus paradoxus. And what are the respiratory pathologies where you will have cardiac tamponade? Respiratory pathologies where you will have the pulsus paradoxus. Respiratory pathologies where you have pulsus paradoxus. So respiratory pathologies where you have the presence of the pulsus paradoxus is, right, that is in case of severe COPD, right? And next in patients with status asthmaticus, right? Status asthmaticus, okay? And even in patients with obesity, you can have your pulsus paradoxus. And even in patients with hypovolemic shock, even in patients with hypovolemic shock, you will have the pulsus paradoxus. These are all the conditions where you will have pulsus paradoxus. Okay, yeah, pulsus alternans. What are the conditions where you have the pulsus alternans? Anyone? Very good, Burani. So you get this pulsus alternans in case of severe left ventricular failure. In severe left ventricular failure, you will have this pulsus alternans. And where do you get this pulsus parvus attitudus? So pulsus parvus attitudus is that where you have a slow rising pulse with late peaking. That is what is called pulsus parvus attitudus. And where do you get that? Very good, Burani. Excellent. That is in case of the aortic stenosis. Okay. Then where do you get this pulsus bigeminus? Pulsus bigeminus is that you have a strong pulse, then followed by that a weak pulse, right? And then you have a compensatory pause. Then you have a compensatory pause. Where do you get this? No, not in HOCM. Not in HOCM. Not in HOCM, yaar. In HOCM, you get pulsus bispherians. HOCM, you get pulsus bispherians. Anyone? Pulsus bigeminus? No, not AV block, not arrhythmias, not aortic regurgitation. Let me see who we can answer. Very good. So Kailash Khatri has answered it. Very good, Kailash Khatri. So it is digoxin toxicity. In digoxin toxicity, you get what is called ventricular bigeminy, right? And ventricular bigeminy pulse that you will have is pulsus bigeminus. Okay, digoxin toxicity, you will have this, right? Then water hammer pulse, right? That is like you can answer this very easily without any problem. That is aortic regurgitation. But which other valvular heart disease you have this pulsus your water hammer pulse? What other cardiac condition you have this water hammer pulse? That is which valve? Very good, Ruchika. So mitral regurgitation, you will have this water hammer pulse, and all your hyperkinetic states you can have the water hammer pulse, right? Next, dicrotic pulse. Yeah, please tell me what is a condition where you have dicrotic pulse. So dicrotic pulse means like where the individual will have one peak in systole and another peak in diastole. That is called dicrotic pulse. Yeah, please tell me what is that. Yeah, very good, Ruchika and Burani. You get that in case of dilated cardiomyopathy. Now you people tell me what are the conditions where you will have the pulsus bis varians. Yeah, now you tell me now. Pulsus bis varians. Right? Yes. So pulsus bis varians is there in AR, then AS with AR, then in HOCM. So what is pulsus bis varians? Pulsus bis varians is that where the individual will have two peaks in systole. That is what is called the pulsus bis varians. All right. So this is about the various abnormal characters of the pulse, which you need to revise just before going to the exam. Then another basic topic that you need to know is regarding the JVP, that is the jugular venous pulse. Okay, so regarding this jugular venous pulse, what is that you need to know is it is the one which will represent the right heart pressure. And what is the normal JVP is around 6 to 8 centimeters above the right atrium. And in the JVP, you need to know these waves, right? What are these waves? A, C, X, V, Y. And A wave is due to what? Anyone? A wave is due to what? So A wave, that is due to the atrial contraction, right? And C wave is due to what? That is due to bulging of the tricuspid valve cusp into the right atrium. Then X wave is due to atrial relaxation. V wave is due to venous filling. Y wave is due to atrial emptying. Okay, so these are the right. Chalo, chalo, theek hai, no problem. Right. Yes, Multani. Now you tell me. Your atrial contraction corresponds to which phase of the cardiac cycle? Which phase of the cardiac cycle your A wave corresponds to? A wave corresponds to which phase of the cardiac cycle? Anyone? No, 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 no. See, don't correspond to your P wave. I'm not asking about the ECG. I'm asking about like the cardiac cycle. Your P wave is what? ECG, right? I'm asking about like which phase of the cardiac cycle. Very good, Cupcake. But Cupcake, can you tell me like there are totally 5 phases in diastole? Yes, Mandar and Multani. There are 5 phases in diastole. Right. Very good, Multani. So that will be your late diastole. That will be your late diastole. Okay. And C wave corresponds to which phase of the cardiac cycle? C wave corresponds to which phase of the cardiac cycle? Yes. So C wave, very good. That will correspond to your isovolumetric contraction phase, which is nothing but your early part of the systole, which is nothing but early part of the systole. So your X wave corresponds to what? So after your early part of the systole, what is that you will have? You have mid systole, right? Then your V wave, it corresponds to late part of the systole of the cardiac cycle. And your Y wave corresponds to which part of the cardiac cycle? Which part of the cardiac cycle will be your Y wave? Very good, Cupcake. So that corresponds to your early diastole, early part of the diastole. Okay, that will be your atrial emptying. Okay, that is nothing but your first rapid filling. First rapid filling is nothing but your early part of the diastole itself. Now, at the same time, you need to be very much aware of the abnormalities related to your waves. So you take the conditions where the A wave is absent. What is the condition where the A wave is absent? The condition where your A wave is absent Very good, Katri. That is in atrial fibrillation, the A wave is absent. Now, what are the conditions where you have the giant A wave? Conditions where you have giant A wave. Giant A wave, you see that in patients with right atrial myxoma, right? You see that in patients with tricuspid stenosis, pulmonary stenosis, and pulmonary hypertension. Okay, so you have to remember it as two conditions as right ventricular inflow obstruction, that is right atrial myxoma and tricuspid stenosis. Two conditions as right ventricular outflow obstruction, that is pulmonary stenosis and pulmonary hypertension. Okay, right. And what are the conditions where you have the presence of Cannon A wave? Cannon A wave, you get that in patients with the complete heart block, right? And Cannon A wave, you get that in case of the junctional rhythm. Junctional rhythm and complete heart block, you have this Cannon A wave. Okay, so this is about the story of abnormalities related to your A waves. Then abnormalities of the X wave. So now tell me, what are the conditions where the X wave is accentuated? Yes, conditions where the X wave is accentuated. X wave is accentuated in case of your constrictive pericarditis, restrictive cardiomyopathy, and as well as the cardiac tamponade. These are the conditions where you have the X wave being accentuated. What is the condition where you have reversal of the X wave? What is the condition where you have the reversal of the X wave? Reversal of the X wave, you get this in patients with tricuspid regurgitation. This is about the abnormalities related to your X wave. And you take the V wave. Now, what are the conditions where the V wave is increased? That is in patients with tricuspid regurgitation, right? And lastly, you need to be very much aware of the abnormalities of the Y wave. Abnormalities of the Y wave. So please tell me the condition where you have the early deep Y descent. Anyone? The conditions where you have the early deep Y descent. Early deep Y descent, you get that in case of, no, not in cardiac tamponade. That is in TR, tricuspid regurgitation, right? And where is that you have deep Y descent? Deep Y descent, you see that in patients with constrictive pericarditis and as well as the restrictive cardiomyopathy. And where do you have absent Y wave? Absent Y wave, you get this in case of the cardiac tamponade, right? And where do you get the slow Y descent? Slow Y descent, you get that in case of tricuspid stenosis, okay? Actually, these are all concepts which are there in a detailed theory class, right? There are a lot of concepts behind these conditions, why you get these abnormalities, because it's just a revision class, right? I'm just giving you only the conditions where you have this, okay? Right. Now, Kussmaul sign and Kussmaul's respiration. Yeah, please tell me where all you get this Kussmaul sign. What are all the conditions where you get this Kussmaul sign? And what is Kussmaul sign? First of all, you need to know that. So Kussmaul sign, ayyo, who is that? Prithviraj. Prithviraj, you should never say that cardiac tamponade Kussmaul sign is present. Okay, so in cardiac tamponade, your Kussmaul sign is absent, which is very, very important that you need to know. Okay, what is Kussmaul sign? Kussmaul sign is increase in the JVP with inspiration. That is what is called as the Kussmaul sign. And you get this Kussmaul sign in patients with restrictive cardiomyopathy, constrictive pericarditis, and any condition which is causing right heart failure. Any condition which is causing right heart failure. Okay, then followed by that Kussmaul's respiration. Kussmaul's respiration is that where there is increase in the rate of respiration, right? And there is also increase in depth of respiration, right? Increase in rate and as well as depth of respiration. So where do you get this? This you get in case of DKA, that is diabetic ketoacidosis. So Kussmaul sign, cardiac condition. Kussmaul's respiration, it is your DKA, diabetic ketoacidosis. Okay, so that was about your the points related to the JVP, right? So I'll just wind up at this point. We will take the remaining part of the discussion in the third part, okay? Because it's almost like 4 hours since 6 o'clock, right? I'm just continuously speaking. So we will just wind up the session here. I will take the third part as well. So don't worry about that. So wherein I'll be covering the remaining part of your cardiology, GIT, hepatology, and okay. Right. So I'll just wind up the session here and see you again in the third part. Thank you very much. Yeah, yes, Cupcake. I will do the NEET PG questions also. NEET PG questions, I'll do that on my Telegram channel, right?